This presentation is going to review the alterations in digestive function. Just a reminder to go back and review the structure and function, or the anatomy and physiology of the GI system. Let's first discuss the clinical manifestations of gastrointestinal dysfunction, starting with the term anorexia. Anorexia is a term that we use to describe the lack of the desire to eat despite having the physiological stimuli that would normally produce hunger in a person. When we use the term vomiting, this is the forceful emptying of the stomach, and usually it's affected by GI contractions and reverse peristalsis of the esophagus. It's going to be preceded by nausea and retching, oftentimes, and with the exception of projectile vomiting, which you can see on the bottom of the slide, it is associated with direct stimulation of the medulla oblongata, and this is known to be the vomiting center of the brain. With projectile vomiting, this is spontaneous. It doesn't have to do with the medulla oblongata, and it's not preceded by nausea or retching. It's usually direct stimulation of a neurological lesion, putting direct stimulation on the vomiting center, and this is what's causing that projectile vomiting. It's important to understand that connection to a neurological disorder, whether it is an actual lesion, intracranial pressure, an aneurysm involving the brainstem. These are the major causes of projectile vomiting in an adult, and we wouldn't want to just rule out GI abnormalities. We also need to rule out neurologic abnormalities as well. The metabolic consequences of vomiting are fluid and electrolyte loss, acid-base disturbances, including hyponatremia, hypokalemia, hypochloremia, and metabolic alkalosis. And lastly, we'll talk about nausea and retching. Just in general, this is mostly nausea as a subjective finding, and it usually precedes vomiting, but they have distinct entities. Now, nausea is a very subjective experience that's associated with conditions including visceral pain, maybe even motion sickness or labyrinthine stimulation. Also, this is what we're calling motion sickness, and the use of opiates as well can cause this nausea. Now, there are specific neural pathways that have been identified for nausea. We also have hypersalivation, tachycardia, which are common symptoms associated with nausea, where retching is the muscular event of the actual action of vomiting. And this is without the expulsion of any vomitus. So retching is without vomitus. So going back to what vomiting is just in general. Now, usually we have deep inspiration that stimulates glottis closure, which will stimulate an intrathoracic pressure fall. Distends esophagus, your abdominal muscles will contract, and your lower esophageal sphincter and the body of the stomach will start to relax. However, the duodenum and the antrum of the stomach will start to spasm. This will cause a reverse peristalsis, and that pressure gradient and force of chyme that comes from the stomach to the duodenum will then move into the esophagus. Now, the upper esophageal sphincter is closed, but chyme doesn't enter the mouth. But the stomach contents will drop back into place. Again, I just want to reiterate that the vomiting center of the brain is in the medulla oblongata, and it includes the reticular formation as well, the tractus solitaris, and the parabrachial nucleus. When we have projectile vomiting, it's not just a GI dysfunction, but you also have to think about the neuro implications. We must also talk about constipation in terms of a GI dysfunction. And constipation, by definition, is a difficult or infrequent defecation, often caused by unhealthy diet, bowel habits combined with a lack of exercise. Now, it can result from a disorder that impairs your motility of your intestines, or it could obstruct the intestinal lumen itself. In terms of the pathophysiology of constipation, it can be primary or secondary. When we talk about primary constipation, it's generally classified into three different categories. We have functional, which has to do with normal transit, so functional constipation. And this is when there's a normal rate of stool passage, but it's very difficult for stool to evacuate. Then we have to understand too that functional constipation is the most common type of constipation and is associated with sedentary lifestyle, having low residue diet, meaning that you aren't consuming highly fibrous foods and you have a diet that is more refined foods, or you're not drinking enough fluid, primarily water. And this is going to decrease the volume and the number of stools that you have, and it contributes to constipation. Also, a lack of access to being able to use the toilet or having consistent suppression of that urge to empty the bowel. So you're holding your bowel movements, and dehydration can also be other causes of functional constipation. The next type of constipation is secondary. It's a slow transit constipation. Excuse me, this is not a secondary. This is still, we're talking about primary conditions. It's a slow transit constipation, and this is when you actually have an impairment in colonic motor activity. And what you will see is infrequent bowel movements. The patient would be straining to have a bowel movement. There may be mild abdominal distension, and you can actually palpate stool in the sigmoid colon. The last of the primary types of constipation is under the umbrella pelvic floor dysfunction. Now, pelvic floor dysfunction can also affect your ability to urinate properly, but in terms of constipation, this person will have difficulty expelling stool because the pelvic floor muscles or the anal sphincter muscles can't relax properly. Think about someone that has pelvic floor dyssynergia, where they can't really control how their pelvic floor is relaxing and contracting. Someone that has rectal fissures or a fistula, someone that has strictures or hemorrhoids, they would all have difficulty controlling their bowel movements with pelvic floor dysfunction. Okay, now we're finally moving on to the secondary conditions. And secondary conditions to cause constipation are usually because of diet, medications, or you have an underlying neurogenic disorder. So think of someone that has had a stroke, someone that has had a chronic motor neuro disease like Parkinson's, a spinal cord injury, multiple sclerosis, among other things. Now, in this secondary constipation, we know that neurotransmitters or neural pathways are either diseased or they have become degenerated enough to cause a delayed colon transit time. Antacids that contain calcium carbonate or aluminum hydroxide, anticholinergics, iron, and bismuth, they all tend to inhibit bowel motility as well. So in addition to the neurogenic disorders, think about the medications. Opioid-induced constipation, this is caused by opioid drugs that activate the mu-opioid receptor in the gut, and it will slow transit time. Endocrine or metabolic disorders are also associated with constipation, like hyperthyroidism, diabetes, hypokalemia, hypercalcemia. Someone that has a hiatal hernia in the pelvic area, so this is the herniation of the bowel through the pelvic floor. This can also cause secondary constipation. Anyone with diverticulitis, irritable bowel syndrome, they will all have secondary constipation. Pregnancy would also be an example of secondary constipation or something that caused secondary constipation. And then think about the aging adult. Aging in general can result in constipation because we have changes in our neurons in the myenteric plexus, and this is going to decrease the neurotransmitter function, decrease your colon motility. While you're aging, we're probably using more medications, and we also have comorbidities that will slow the transit time of our bowels as well. Now, when we have changes in our bowel evacuation patterns, we want to ask our patients things like, are you having a bowel movement every day? So, what we're going to see is less frequent defecation. When they talk about their stool patterns, they may also, in addition to not having a bowel movement every day, it may be smaller stool volume, hard to pass stools, and lots of straining. They might even still feel full despite having a bowel movement. It's very uncomfortable. They may notice blood in the stools. All of those things require further investigation and assessment. When we use the term fecal impaction, you're thinking about hard, dry stools that are retained in the rectum, and this is associated with rectal bleeding, abdominal cramping, nausea, vomiting, weight loss. And we have episodes of diarrhea as well, and you're probably wondering, well, how can we have diarrhea if we are impacted? These hard, dry stools stay within the colon, and the only thing that can come out from the sides are the wet stools like diarrhea. We can also have compression of capillary perfusion in the intestinal walls, and this can lead to further damage like ischemia and necrosis. It's not good to strain to evacuate stools because this is going to cause engorgement of hemorrhoidal veins and can cause a rupture of those veins, and this is what causes the bleeding. We have hemorrhoidal disease, thrombosis with rectal pain, bleeding, and itching. So this is all under the umbrella of hemorrhoids. Additionally, if you are passing hard stools, this can cause painful anal fissures, and you will also see bleeding in these cases as well. So on the bottom of the slide, you can see indicators of constipation. They need to include 2 of the following for at least 3 months. Straining and defecation at least a quarter of the time, lumpy or hard stools at least a quarter of the time, sensation of being incomplete even after you've had a bowel movement about a quarter of the time. If you've needed any manual maneuvers to facilitate stool evacuation for at least 25% of the time, and then if you are having less than 3 bowel movements every week, this is also a criteria for constipation. So again, 2 of these 5 in the last 3 months. You can use the Bristol stool chart to help you discuss stool patterns with your patients so that they can describe what the consistency of their stool looks like, and can give you an idea of how severe their constipation is. Now we're going to move on to diarrhea. Now, diarrhea, by definition, is the presence of frequent loose watery stools, and usually it's caused by excessive fluid being drawn in or attracted back into the intestinal lumen by osmotic forces. This is called osmotic diarrhea. And this excessive secretion of fluids by the intestinal mucosa could be the secretory or infectious type of diarrhea. Or lastly, it has to be motility diarrhea, which has to do with excessive GI motility. So those are the 3 ones: osmotic diarrhea, secretory or infectious diarrhea. This is the second one. And then motility diarrhea would be the third one. When we talk about acute diarrhea, this is when someone's had more than 3 loose stools within 24 hours and have lasted less than 2 weeks or 14 days. When we talk about someone that has persistent diarrhea, we're talking about someone that has had diarrhea that lasted 14 to 30 days, and chronic diarrhea lasts longer than 30 days. Now, there are many factors that determine the stool volume and the consistency, and we talked about fiber being one of them, but also water, the water content of the colon, what you're eating, and any unabsorbed food, unabsorbable material, and the secretions in your intestinal lining. Now, the average adult the stool volume is less than 200 grams per day. In a child, it really depends on the age and the size of the child. Your adult intestine should be able to process about 9 liters of luminal contents every single day. 2 liters should be ingested, and the remaining 7 liters consist of intestinal secretions. Of this volume, 99% is absorbed in the small intestines, and the rest is absorbed in the colon. Approximately 150 mLs of water is excreted daily in your stool. So then what causes diarrhea? Well, this is when the volume of the feces is increased. This is called large volume diarrhea. Large volume diarrhea generally is caused by excessive amounts of water secretions, or it could be both, in the intestines. When we have small volume diarrhea, this is when the volume of the feces is not increased, but usually this is the result from just excessive intestinal motility. So you may not have a lot of volume in your diarrhea, but your intestines is just moving very, very quickly. That GI motility is happening so quick that it doesn't have a chance to bulk up and you have loose stool. Now, small volume diarrhea usually is caused by an inflammatory disorder of the intestines. So think of things like ulcerative colitis or Crohn's disease, or even microscopic colitis. The inflammation of the colon causes your smooth muscle to contract, and this is what's causing the cramping pain, the urgency, and the frequency in some of these GI diseases. Now, small volume diarrhea also can be caused by a fecal impaction, like we talked about earlier. So if you have severe constipation, then that diarrhea will seep around that blockage. Diarrhea consists of secretions like mucus and fluid, and this is produced by the colon to lubricate that impacted feces. It moves it toward the anal canal and it seeps around it. These secretions flow around that impaction, and it's going to cause, again, a low volume secretory diarrhea. So there are 3 major mechanisms of diarrhea. So we talked about them already: osmotic, secretory, or motility. In osmotic diarrhea, there is a non-absorbable substance in your intestines, and it's drawing water into the lumen by osmosis. By doing this, it's going to increase the stool weight and the volume. And so again, it's the large volume diarrhea. Now, large oral doses of poorly absorbed ions such as magnesiums, sulfate, phosphates, these can all cause interluminal osmotic pressure. Whenever we have excessive ingestion of synthetic sugars or non-absorbable sugars like sorbitol, this can also cause large volume diarrhea. This introduction of full-strength tube feedings and formulas and dumping syndrome, this is also associated with gastric resection. These surgeries and processes can actually start to draw water into that intestinal lumen. It appears when the ingestion of whatever osmotic substances stops, then also this osmotic diarrhea will disappear. Malabsorption that's related to lactase deficiency, pancreatic enzymes or bowel salt deficiencies, and small intestine bacterial overgrowth or celiac disease, these are other factors that can cause osmotic diarrhea. With secretory diarrhea, we need to think about infectious causes like viruses, like rotavirus, bacteria enterotoxins like E. coli. These can also cause a secretory diarrhea. You can think about Clostridium difficile or C. diff. This is something that follows antibiotic therapy, or small bowel bacteria overgrowth. Again, all leading to secretory diarrhea. These infections cause the secretions of the neurotransmitters from the enteroendocrine cells, like 5-HT, and activates the afferent neurons, which will stimulate the submucosal secretomotor neurons. And altered sodium and chloride transport results in decreased water absorption. Other things like neoplasms can also produce hormones that will stimulate intestinal secretions, causing diarrhea. And then lastly, if you think about motility, this usually is because of the resection of small intestines, or someone that has short bowel syndrome, someone that's had a surgical bypass. So think about some area of your intestines being removed, or if they've had a fistula form between the loops of the intestines, irritable bowel syndrome. These will all produce motility diarrhea. Someone that has diabetic neuropathy, hyperthyroidism, or someone that's abusing laxatives will also have motility diarrhea. This motility decreases your transit time. Therefore, the mucosal surface contact and opportunities for your fluid to actually be absorbed gets limited, which will result in diarrhea. Abdominal pain is a symptom that sometimes is mostly subjective, so it's whatever they are feeling and able to describe. And it's associated with a number of GI diseases and processes, and it can be acute or chronic. The pathophysiological mechanisms are mechanical, inflammatory, or ischemic. The person will present with abdominal pain that could be generalized to the entire abdomen or localized to a particular abdominal quadrant. And you can see here, just like you learned in health assessment, that depending on where this localized pain is and what quadrant, you can see by either referred pain or direct organs below what that pain may be derived from. Now, the pain can be variable. It can be described as sharp, dull, or even colicky. Generally, the abdominal organs are not sensitive to mechanical stimuli, such as cutting, tearing, or crushing. However, they are sensitive to stretching and distension, which can activate nerve endings in your hollow and your solid structures. This onset of pain is associated with rapid distension. Gradual distension causes only a little pain. Okay, so if it's a rapid distension, then it would produce abdominal pain. Other things like traction on the peritoneum caused by adhesions, distension of the common bile duct, or forceful peristalsis can result from intestinal obstruction. These will all cause pain as well, because of the increased tension that it's putting on the organ. There are capsules that surround your solid organs, such as your liver, your gallbladder. These capsules contain pain fibers that can be stimulated whenever there is stretching or if the organs begin to swell. When someone talks about abdominal pain, we can further characterize it into something that is parietal pain, or sometimes we use the term somatic, visceral pain, or referred pain. We talk about parietal pain. This is from the parietal peritoneum, and it's localized and it's more intense than visceral pain, which arises from the organ itself. So when we talk about visceral pain, we're talking about pain derived from the organs. And then the nerve fibers from the parietal peritoneum are predominantly the A delta fibers. Remember that those A delta fibers can travel with somatic peripheral nerves to the spinal cord, and the sensation of pain will correspond to your dermatomes, T6 to L1. That parietal pain will lateralize at any particular point in the parietal peritoneum. It's going to innervate, and then you can feel the pain from this system. Now, in terms of visceral pain coming from a stimulus like distension, inflammation, or ischemia, this is going to act on your mechanical and your chemical nociceptors of the abdominal organs. Visceral pain, however, compared to somatic pain, is poorly localized. You will have patients that will say, yeah, it's kind of dull, and it's really difficult to describe. Okay, so that's visceral pain. It's diffuse, it's vague, and the reason why is because the nerve endings in the abdominal organs, these are predominantly unmyelinated C fibers. They're sparse, multi-segmented. And pain arising from your stomach, for example, is experienced as the sensation of being full, cramping, or you have this gnawing pain in the mid-epigastric area. And then lastly, referred pain. This is a visceral pain, however, it is felt at another place, felt at some distance from the disease or the affected organ. Referred pain is usually well localized and it's felt in the dermatomes again, or it can be felt in the deeper tissues because visceral afferent neurons and regional somatic neurons converge at the second order neurons at the same level at the spinal cord. And that's why it can either be the skin dermatomes or the deeper tissues. Let's take the gallbladder for existence. Gallbladder pain can be referred to the right shoulder or the scapula. In terms of abdominal pain, we also need to talk about the biochemical mediators of inflammation, like histamine, bradykinin, serotonin. These will all stimulate your pain nerve endings and produce abdominal pain. The edema and vascular congestion that accompany chemical and bacterial and even viral inflammation can cause painful stretching. This obstruction of blood flow from the distension of bowel obstruction or the mesenteric vessel thrombosis can produce pain of ischemia and will increase the concentration of tissue metabolites, which will also stimulate your overall pain receptors. So if someone were to ask you, what are the different types of pain, you should be able to verbalize the difference between somatic, which is also called parietal, visceral pain, and referred pain, and talk about their pain pathways. In terms of GI bleeding, we have different types of GI bleeding. The first one could be occult bleeding, and this is usually detected by testing your stool or your vomitus, and we're checking for the presence of blood. Someone that has chronic blood loss, for instance, you might find it in terms of if it's an upper GI, it would be vomitus. If it was lower GI, it'd be testing the stool. Someone that has chronic blood loss would eventually end up with iron deficiency anemia, for instance. Someone that has coffee ground emesis, this is grainy digestive blood. And the reason why it has this coffee ground look is because stomach acids have been introduced and mixed with the blood, giving it that presentation. We also have GI bleeding that can come from varicose veins. We have varices within the esophagus. These can turn into a GI bleed if they are irritated. And then we have the Mallory-Weiss tear. A Mallory-Weiss tear is where you have a tear in the esophageal gastric junction, and usually someone that has severe retching can cause a Mallory-Weiss tear in the esophageal gastric junction. Now, when we talk about GI bleeding, you have to be able to think about it in terms of whether it's an upper GI bleed or a lower GI bleed. The upper GI bleed would be something that is bleeding in the esophagus, the stomach, the duodenum. And we usually use the term frank, bright red blood or bleeding in the emesis, or we'll use dark, grainy digestive blood, or we'll say coffee ground emesis, which would come from the stool. Upper GI bleeding is caused by any bleeding in the esophageal or gastric varices, like we talked about the Mallory-Weiss tear, or cancer. Also, if we have any type of AV malformations, peptic ulcers, or sometimes you're going to get a GI bleed from drugs like NSAIDs, aspirins, SSRIs, and antiplatelets or anticoagulant medications. These can also cause upper GI bleeds. With lower GI bleeds, we're talking about bleeding that comes from the level of the jejunum or ileum, the small intestines, colon, rectum. That could be caused by polyps, someone that has inflammatory bowel disease, diverticulitis, cancer, or hemorrhoids. These are all lower GI bleeds. When we use the term occult bleeding, this is usually caused by slow chronic blood loss. And it's not obvious at first, but just like I was talking about that person with iron deficiency anemia, it's because the bleeding is happening very slowly. And as the iron stores in your bone marrow are depleted, you start to have symptoms of iron deficiency anemia. Now, the physiologic response, as you can see here in this algorithm, to GI bleeding really will depend on the amount of blood loss and the rate that the blood loss is happening. There will first be changes in your blood pressure and heart rate, and these are the best indicators that there have been a massive blood loss in your GI tract. Now, during the early stages of the volume depletion, you'll note that your peripheral arteries, arterioles, they'll start to constrict because they're trying to maintain that level of blood pressure and create hemodynamic stability. They'll shunt blood to the vital organs, including your brain. But as blood loss continues to occur, up to 1,000 mLs or more over a short time, you're going to see a big drop in blood pressure, and you'll see the corresponding heart rate increase to compensate. With any type of GI blood loss of 1,000 mLs or more, your heart rate is going to be greater than 100 beats per minute. Your systolic pressure is going to be less than 100 millimeters per mercury, and you will note some hemodynamic instability. These are the signs of large volume blood loss. You'll also see postural hypotension, which is a drop in blood pressure that happens when you are from a lying to a sitting position or sitting to an upright position. Your patient will have lightheadedness, vision loss. That tachycardia is going to compensate for that low blood pressure, trying to maintain cardiac output and maintain tissue perfusion. However, if that blood loss continues, your patient is at risk for hypovolemic shock. When hypovolemic shock develops, it's going to create exaggerated symptoms, and we'll see diminished blood flow to the kidneys, which will cause decreased urine output or even lead to oliguria, which is low urine output, tubular necrosis, renal failure. Ultimately, if we continue to have insufficient blood flow or blood volume, you'll have insufficient cerebral and coronary blood flow, and this can cause irreversible anoxia and even death. So, important to understand the pathway of GI bleed and where the most common upper GI bleeds happen, the lower GI bleeds happen. What types of tests or signs and symptoms can you use to determine the type of GI bleed, and looking for your vital signs and symptoms to decide if your patient is entering hypovolemic shock. Now, acute severe GI bleeding is life-threatening depending on the volume. Again, 1,000 mLs is kind of the threshold there when you start to see very exaggerated symptoms. We're also looking to see if there's accumulation of blood in the GI tract, because this can be irritating. It can increase peristalsis, causing vomiting. We call this hematemesis when it's vomiting of blood, or diarrhea, or even both. If bleeding is from the lower GI tract, the diarrhea is frankly bloody. If bleeding is coming from the upper GI tract, it's going to produce bright red stools. We call this hematochezia. But generally, some digestion of blood components will have occurred, and so this is causing melena, which is black or tarry stools that are sticky and have a very characteristic foul odor. The digestion of blood proteins originating from massive upper GI bleeding, this is going to be reflected in the increase in your blood urea nitrogen, or your BUN blood levels. We're moving on to the disorders of motility, and we're going to discuss dysphagia, which is a difficulty swallowing, or it could be the perception of an obstruction during the process of swallowing. And it can be classified either as oropharyngeal or substernal esophageal. It really depends on the location of the sensation of difficulty swallowing. Now, it could either be mechanical or it could be functional. Mechanical obstructions can be intrinsic or extrinsic. An example of intrinsic would be something that's originating from the wall of the esophageal lumen itself. Tumors, strictures, maybe there's a diverticular herniation or outpouching within the esophagus. These are all causes of intrinsic mechanical obstruction. Extrinsic mechanical obstructions, these are going to originate outside the esophageal lumen and narrow the esophagus by pressing inward or putting pressure on the esophageal wall. And the most common cause of an extrinsic mechanical obstruction is a tumor. Functional dysphagia is caused by a neural or muscular disorder that interferes with the voluntary swallowing or peristalsis. And disorders that affect the striated muscles of the upper esophagus interfere with your voluntary or oropharyngeal phase of swallowing. And typically it's caused by upper esophagus and neurologic impairments caused by stroke, multiple sclerosis, Parkinson's, ALS, or even myasthenia gravis. The term achalasia is a rare disorder related to the loss of inhibitory neurons in the myenteric plexus. And this is with the smooth muscle atrophy. It's going to happen in the middle and the lower portions of the esophagus. And the etiology is not known, but it can be related to the cell-mediated and antibody-mediated immune response system. Now, the loss of inhibitory myenteric innervation and the loss of esophageal peristalsis, failure of the LES or the lower esophageal sphincter relaxation, can cause a functional obstruction of that lower esophagus. And as food accumulates above that area of obstruction, it can actually distend your esophageal lining. It will cause dysphagia. Cough and aspiration can occur in this instance. And think about all that pressure increasing. This is called hydrostatic pressure. That food is slowly being forced past that level of obstruction into the stomach. When we have chronic inflammation from that food retention in the esophagus, this can increase your risk for esophageal cancer. The list of manifestations are below here. Stabbing pain at the level of obstruction. You'll have discomfort after swallowing, regurgitation of undigested food. Your patients will complain of just not being able to taste very much, and it's very unpleasant when they eat, vomiting, aspiration, and weight loss. Another disorder of motility is GERD, gastroesophageal reflux disease, and the abnormalities in your lower esophageal sphincter is the primary reason your patients will suffer from GERD. There's motility issues and or emptying that causes that reflux of acid and pepsin that are in your stomach to move up to the esophagus, causing esophagitis. Now, your resting tone of this lower esophageal sphincter tends to be lower than normal in GERD. And this is either from transient relaxation or there's a weakness in this esophageal sphincter. Delayed gastric emptying can also contribute to your reflux esophagitis because you're lengthening or extending the period where reflux can actually be possible. This will increase the acid content in your chyme or that ball of food, and the conditions that can increase abdominal pressure or delayed gastric emptying can contribute to the development of reflux esophagitis. Now, we also have to understand, well, what would cause that resting tone to be lower than normal? Things like vomiting, coughing, lifting, bending, obesity, and even pregnancy can increase the overall abdominal pressure. This can contribute to that development of reflux esophagitis. Another condition associated with GERD is hiatal hernia, and this can weaken that lower esophageal sphincter. Hiatal hernia is when part of your stomach is pushing past through the diaphragm. There are several risk factors associated with GERD. Obesity, hiatal hernia, which we talked about, and other things like drugs or chemicals can also relax that lower esophageal sphincter. Drugs like nitrates, calcium channel blockers, nicotine, and anticholinergics. GERD may also trigger asthma because you are having that consistent irritation in the esophagus. It can trigger chronic cough and sinusitis as well. Your patients are going to mostly complain of heartburn, acid regurgitation, dysphagia, chronic cough, asthma attacks, laryngitis, and most importantly, this is very distinct of GERD, is that they'll start to have abdominal pain within an hour of eating. Someone with severe reflux esophagitis is going to have these symptoms because the gastric content is so high in acids and bile salts in the pancreatic or intestinal enzymes that it irritates that lining even more. It increases exposure to that mucosal injury and inflammation with hyperemia, increased capillary permeability, edema, tissue fragility, erosions, and ulcerations are going to all occur again because of this increased exposure to the stomach acids and bile salts. Now, someone that has GERD over time, if it isn't corrected or the symptoms managed well, then it can lead to fibrosis and thickening in the esophagus and the esophageal lining. This can cause precancerous lesions leading to Barrett's esophagus. Now, we alluded to hiatal hernia a little bit previously, but let's define it. It's the diaphragmatic herniation with protrusion to the upper stomach, that upper stomach area, through the diaphragm into the thorax. And so there's three different types. There's the sliding hiatal hernia, the paraesophageal hiatal hernia, and the mixed hiatal hernia. So starting with type 1, the sliding hiatal hernia, this is where the proximal portion of the stomach is moving into that thoracic cavity and is through the esophageal hiatus. An opening in the diaphragm for the esophagus and the vagus nerves to push up. In type 2, paraesophageal hiatal hernia, the herniation is going to be at the greater curvature of the stomach, and it's through that secondary opening of the diaphragm. And then we have mixed hiatal hernia, and this is the one that's usually associated with GERD, peptic ulcer disease or PUD, cholecystitis, cholelithiasis, chronic pancreatitis, and verticulosis. We also should talk about gastroparesis, which by definition is the delayed gastric emptying in the absence of something mechanical. In most situations, it's associated with patients that have diabetes. They've either had a fundoplication or surgical vagotomy. It can also just be idiopathic. And we don't really understand the pathophysiology very well, but it does involve abnormalities of your autonomic nervous system, your smooth muscle cells, enteric neurons, and your gastric intestinal hormones. Diabetic gastroparesis represents neuropathy involving that vagus nerve and the loss of intestinal cells of Cajal, C-A-J-A-L. When you have diabetic gastroparesis, you will have symptoms of nausea, vomiting, abdominal pain, postprandial fullness or bloating, so after you eat, and weight loss. Typically, the treatments include dietary management, providing drugs to move your intestinals, that motility faster, like prokinetic drugs, and in some cases, gastric electrostimulation, or a pyloroplasty, or even a surgical venting gastrotomy. Now, surgical vagotomies involve cutting or disabling the branches of your vagus nerve. And historically, this is how we treated peptic ulcer diseases before. Now, it's less common because we have medications that are more effective now. Pyloric obstruction is a gastric outlet obstruction, and it narrows or blocks that opening between the stomach and the duodenum. Don't get this mixed up with the opening here at the lower esophageal sphincter, which is predominantly the reason a patient may experience GERD. Okay, so gastric outlet obstruction is down here. It's blocking the stomach and the duodenum. It can be congenital or acquired, and your patients are going to develop epigastric pain and fullness, nausea, succussion splashes, so you can actually hear these big splashes with your stethoscope when you're auscultating, vomiting, and if your patient has prolonged obstruction, malnutrition, dehydration, and extreme debilitation, you can also cause pyloric obstruction. Acquired obstructions are caused by peptic ulcer disease, carcinomas that are near the pylorus. Duodenal ulcers are the most likely cause and more common than gastric ulcers to obstruct the pyloric area. Ulcerations that cause obstruction will result, or obstruction resulting in inflammation, edema, spasms, fibrosis, or scarring, can also cause pyloric obstruction. Now, tumors can cause obstruction here because they will block and grow right into that pyloric area. So in terms of pyloric obstruction, it is a gastric outlet obstruction or stenosis of the pyloric sphincter. Intestinal obstruction can be caused by any type of condition that prevents that normal flow of chyme, or that ball of fluid, moving through the intestinal lumen, or failure of normal intestinal mobility. And it's happening in the absence of a physical obstruction or an ileus. And so obstructions can occur also either in the small or the large intestines. And the small intestine is more commonly obstructed because the lumen of the small intestines is smaller. We have simple obstructions and functional or paralytic ileus obstructions. With simple obstructions, it's a mechanical blockage of the lumen by lesion. When blood flow is preserved, it is the most common type of intestinal obstruction. In a strangulated obstruction, your blood flow is compromised, leading to intestinal ischemia, and if you can't treat it or it's untreated, necrosis and perforation will occur because that intestinal area is being twisted and strangulated, causing obstruction of blood flow. Now, with paralytic ileus or functional obstruction, this is the functional failure of motility after intestinal or abdominal surgery. Someone that's had acute pancreatitis or even hypokalemia can also have a paralytic ileus. Anesthetic agents, local inflammatory reactions, or the use of opioid analgesics can also cause post-operative ileus. And so we are always listening for bowel sounds after a patient is recovering or during the recovery period of anesthesia or post-op surgery, because we're making sure that patient does not have a paralytic ileus. Hyperactivity of the sympathetic nervous system can also contribute to post-op ileus. Simple obstruction of that small intestines from fibrous adhesions is the most common type of intestinal obstruction. Acute obstructions usually are caused by mechanical causes like adhesions or hernias. Someone with chronic or partial obstructions, they're more often associated with either a tumor or inflammatory disorders. And usually it's going to be the large intestines. The reason why intestinal obstructions and paralytic ileus are very important to understand is because they do have severe consequences that affect your fluid and electrolytes. Hypovolemia, shock, intestinal necrosis, and perforation of the intestinal walls are things that we're trying to avoid. This next slide here does show you the different areas of your GI tract and what you might see in terms of signs and symptoms of obstructions within the GI system. With the small intestinal obstructions, your patients will have colicky pain, nausea, and vomiting. With large intestine obstructions, usually it's hypogastric pain and abdominal distension. And you can see using this algorithm that if there is intestinal obstruction, there will be a sequestration of gas and fluid that is proximal to that obstruction, leading to either distension and or a loss of electrolytes. That distension is what's causing that colicky pain, nausea, and vomiting. You have a decrease in food intake, nutrient absorption, and carbohydrate reserves. This loss of electrolytes can eventually occur too because of this distension, and you will lose your water as well as your electrolytes. When you lose early or you have high obstruction, early on you're going to have alkalosis because you're going to have a decrease in acid but an increase in bicarb. If you have late or low obstruction, you will actually have metabolic acidosis because your hydrochloric acid is increasing, but your potassium is low. So you will also see ketosis and lactic acidosis in this case. If these things are not corrected, the distension and the loss of electrolytes, we can further do damage. The distension can put pressure on the diaphragm, lowering respiration, leading to atelectasis and even pneumonia. So we might even cause a secondary infection of the respiratory system. If that distension is not corrected and we have prolonged tension in the interluminal wall, you can decrease venous return, cause intestinal bowel wall edema, and increase capillary permeability can lead to fluid loss in the peritoneum. This can also result in hypovolemia, where you're losing that water and electrolytes, causing dehydration. That dehydration and hypokalemia can cause atony of your GI system. This is also causing hypovolemia as well. Dehydration will lead to a decrease in extracellular fluid volume and plasma volume. And in terms of your hemoconcentration, you will have a drop in central venous pressure, leading to tachycardia. What that means is your systolic blood pressure will decrease and your heart rate will increase to compensate. Now, if we get to this area of hypovolemia, then we are worried about shock. So hypovolemic shock. It can also, the distension can eventually lead to a release of toxins due to increased capillary permeability, which can cause a secondary GI bacterial infection called peritonitis. And signs of peritonitis would be fever. Acute gastritis is caused by injury of the protective mucosal barrier, and it's usually caused by drugs, chemicals, or a H. pylori infection. The lesions in the mucosa can either be deep or superficial, and it could be with or without any bleeding. NSAIDs like ibuprofen, naproxen, indomethacin, and aspirin, they can inhibit that action of COX-1 or cyclooxygenase 1, and it causes gastritis because it inhibits prostaglandin synthesis, which normally can stimulate the secretion of mucus and suppress inflammation. But if we don't have that prostaglandin, because of COX-1 being inhibited, we're at risk for bleeding and hemorrhage. Now, NSAIDs can cause gastric hypermotility, causing the mucosal compression and injury. Alcohol, histamine, and metabolic disorders can also contribute to this as well. H. pylori, this is associated with acute gastritis because it causes inflammation, increased gastric secretion, and it can decrease the gastric secretion in the fundal gastritis. Pain, nausea, vomiting can also be associated symptoms. Shock and hypotension can cause decrease in the mucosal blood flow, contributing to acute gastritis. Chronic gastritis is more severe, and it can occur at any age, and it involves chronic inflammation. So think about mucosal atrophy, epithelial metaplasia. This can progress over years. Now, chronic gastritis is usually classified as either type A, immune, or type B, non-immune. With type A, we have autoantibodies against the parietal cells or intrinsic factor, and this can lead to pernicious anemia. So make sure that you can connect pernicious anemia back to chronic fundal gastritis. Now, type B is more common, and usually we have chronic use of alcohol, tobacco, NSAIDs being contributing factors. In type B, there's high levels of hydrochloric acid secretion, increased risks to duodenal ulcers because of this increased hydrochloric acid. And H. pylori is the main trigger that causes an immune response. It leads to an autoimmune response, atrophic gastritis, and it's involving the fundus. So we call this pangastritis. It is affecting the atrium, and this is more severely involved in this area. Now, there's another type C that I didn't put on here, but just for you to know, it's associated with the reflux of bile and pancreatic secretions in the stomach, and it's usually causing some type of chemical injury. Going back to type A for just a second, I do want you to know that this is the most rare and severe form of gastritis, and it's usually associated with the loss of T cell tolerance and the development of autoantibodies against the parietal cells or intrinsic factor, which you can see on the slide. Peptic ulcer disease is defined by a process where there's either single or multiple breaks or ulcerations in that protective mucosal lining that appears in your lower esophagus, your stomach, or even the duodenum. And we can have acute or chronic ulcers. Usually it's because you are habitually using NSAIDs, aspirin, alcohol, eating poor diet, and H. pylori infection. Now, H. pylori infection of the gastric mucosa is one of the top reasons for PUD. But there could be some superficial erosions to the mucosa that don't penetrate the muscularis mucosa. A true PUD will extend through that muscularis mucosa and damage the blood vessels. And this is when you'll actually have GI bleed, or it will cause hemorrhage or perforating of your gastrointestinal wall. Zollinger-Ellison syndrome is rare, but it is associated with peptic ulcer disease. It's caused by gastrin-secreting neuroendocrine tumor or multiple tumors called gastrinomas of the pancreas or the duodenum. Now, gastrin will stimulate the proliferation of your parietal cells and chronic secretion of gastric acid, so further irritating this area. It will result in excess acid causing gastric and duodenal ulcers. Then we might even have GERD, abdominal pain, and diarrhea as well. To diagnose Zollinger-Ellison syndrome, you will have secretin or calcium-stimulated measures of gastrin levels. They'll measure your gastric pH, less than 2, and symptomatic evidence that there is PUD or peptic ulcer disease. The most common of the peptic ulcers is a duodenal ulcer. It's associated with H. pylori infection, chronic use of NSAIDs, or if you have an increased number in parietal cells in your stomach. Remembering that the parietal cells are the acid secreting cells. You'll also see duodenal ulcers in patients with elevated gastrin levels and rapid gastric emptying. Now, pain is going to occur when the stomach is emptying, it's going to occur when the stomach is empty, and it's relieved when you provide food or antacids. So, knowing that it has to do with increased acids, if you put food in, this can help you. This question in itself can help you understand if it's a duodenal ulcer or not. And these ulcers tend to heal spontaneously, but they can recur very frequently. Duodenal ulcers occur actually more frequently than any other types of peptic ulcer disease, and they are commonly caused by that H. pylori infection. Okay, so very important to understand. Now, idiopathic duodenal ulcers are very rare, but they are associated with alterations in the mucosal defenses, rapid gastric emptying, or if you have elevated serum gastrin levels. Acid production stimulated by smoking can also cause duodenal ulcers. With gastric ulcers, these tend to develop in a different area in the antral region of the stomach. This is something that will distinguish it from a duodenal ulcer. And in this area, it's adjacent to the acid-secreting mucosa of the body. The primary defect in this case is increased mucosal permeability of the hydrogen ions itself. Gastric secretion is normal or less than normal. You can see here that H. pylori, bile salts, NSAIDs, alcohol, or ischemia can damage that mucosal barrier, decreasing the function of your mucosa cells, lowering the quality of the mucus to help lubricate that area, and you might even have a loss of tight junctions between the cells. Now we're going to see a back diffusion of acid back into the gastric mucosa, and there's either conversion of pepsinogen to pepsin, or additionally, there is a formation and liberation of histamine. These factors together will cause an increase in acid secretion. Now, the liberation of histamine will cause local vasodilation as part of that histamine pathway. So you'll have increased capillary permeability and mucosal edema. With the conversion to pepsin, you'll have further mucosal erosion, destroying your blood vessels and bleeding, causing that H. pylori here, that ulceration. And H. pylori can cause mucosal injury, also leading to ulcerations. So these are the different ways that it can result into ulcerations and muscle spasms and mucosal edema. The manifestations and treatment of a gastric ulcer are very similar to duodenal ulcers, except food actually causes pain. So remembering where I was telling you that food relieves the pain in a duodenal ulcer, and a gastric ulcer, it will actually cause pain. So another distinguishing factor, in addition to the region of the stomach where it is located. We also have stress-related mucosal diseases, which are stress ulcers. And this is an acute form of erosive inflammatory peptic ulcer that leads to accompany the physiological stress of a severe illness or some type of major trauma or multiple organ failure. Also, think about severe burns or head injury. These can also cause stress ulcers. Now, usually you'll see multiple sites of ulceration, and it could be distributed within the stomach or even the duodenum. These stress ulcers can be classified as either ischemic, curling, or Cushing's. You see, with the ischemic ulcers, they are going to develop within hours of when the actual trauma or the burn or the hemorrhage occurred. And it causes ischemia of the stomach and the duodenal mucosa. Stress ulcers that develop as a result of burn, we usually call them curling ulcers. Okay, so this is a subtype caused by burns. And Cushing's ulcers, they usually develop because of a result of brain injury or a brain surgery. So curling and Cushing's are types of ischemic ulcers that are stress-related mucosal disease ulcers. Post-gastrectomy syndromes are important to understand because they can cause severe GI issues with our patients. And usually, patients that are undergoing some type of post-gastrectomy are trying to lose weight and better their life and improve their health. But it can cause other issues like alkaline reflux gastritis. This is when you have stomach inflammation caused by the reflux of bile and pancreatic secretions from the duodenum in the stomach, and they disrupt the mucosal and cause inflammation. Afferent loop obstruction is obstruction of the duodenal stump on the proximal side of the gastroduodestomy. Biliary and pancreatic secretions will accumulate in that stump, and you will actually see distension in that area. Your patient will complain of intermittent pain and even vomiting. Now, of these post-gastrectomy syndromes, dumping syndrome is important to understand. There's a lot of questions about dumping syndrome. This is a rapid emptying of chyme in the small intestines, and it's because of osmotic shift of fluid from that vascular compartment moving into the intestinal lumen, which is going to decrease the plasma volume. This usually happens residually. That leftover stomach, because you remember you are altering that stomach overall, so we call that residual stomach. And you will see that because of that, there is this rapid emptying of hypertonic chyme into that small intestines that usually occurs within 10 to 20 minutes after we eat. And it can vary in severity. We know that about 10% of patients have undergone some type of partial gastrectomy will have dumping syndrome. Now, factors that promote early dumping syndrome will include that loss of gastric capacity, that loss of emptying control when you've actually removed the pylorus, and that loss of feedback control by the duodenum when we remove that area. That gastric emptying becomes faster, and it creates this non-physiologic high osmotic gradient in that small intestines. That plasma volume is going to decrease, causing vasomotor responses. So you will see in your patient increased pulse rate, hypotension, weakness, pallor, sweating, dizziness, and you might even notice rapid distension. It's going to produce a feeling of epigastric fullness, cramping, nausea, and vomiting. Diarrhea can accompany dumping syndrome, or it can be its own solitary symptom. It can be frequent, persistent, or precipitous. A less common form of dumping syndrome, however, is the late dumping syndrome. So all of that was early dumping syndrome. But with late dumping syndrome, this is going to happen 1 to 3 hours after eating. And your patients are more commonly going to discuss weakness, diaphoresis, and confusion as being part of their symptom profile. When they eat high carb meals, after they've had gastrectomy or gastric bypass, this is going to develop hypoglycemia. That hypoglycemia is because of increases in insulin secretion stimulated by the hyperglycemia that follows eating. Other hormonal responses can participate as well in developing that hypoglycemia. So whenever you have a patient with gastric bypass, within about 1 to 3 hours of eating, you want to check their blood sugar to make sure that they have not dropped to hypoglycemic levels. Okay, so again, the hypoglycemia is caused by an increase in insulin secretion that was stimulated by the hyperglycemia that followed that high carb meal. Most causes of dumping syndrome respond really well to dietary management, but you have to educate your patient on frequent small meals that are high in protein and low in carbs. And this is going to overall help with the symptoms of dumping syndrome. So we will practice. This says a female patient undergoes a gastric resection. Following the surgery, she experiences intermittent severe pain, epigastric fullness. Which of the following is the most likely reason for her symptoms? So, of the 4 choices, we know it's not diarrhea. It's either B, C, or D. You see here that it talks about epigastric fullness after eating. So, although all of the choices can happen after post-gastrectomy, afferent loop obstruction is the one that produces intermittent pain following eating. Dumping syndrome is the rapid emptying of chyme into the small bowel and results in cramping, nausea, diarrhea. And alkaline reflux gastritis is stomach inflammation caused by the reflux of bile and alkalinic pancreatic secretions. And this is going to result in epigastric pain that worsens following eating. So here, let's read it again. It says she experiences intermittent severe pain and epigastric fullness after eating. So therefore, this has to be afferent loop obstruction. Afferent loop obstruction because it is the one that produces intermittent pain following eating. Now we're moving on to malabsorption syndromes, maldigestion, malabsorption. Malabsorption syndromes will interfere with your nutrient absorption in your small intestines. Historically, malabsorption disorders have been classified as either maldigestion or malabsorption. Maldigestion is the failure of chemical processes of digestion that take place in the intestinal lumen, or at that brush border of the intestinal mucosa of the small intestine. While malabsorption is the failure of this intestinal mucosa to actually absorb and transport that digestive nutrients to the rest of your body. And the two syndromes are often interrelated and can occur together. So it makes this classification really difficult. But generally, maldigestion is caused by deficiencies in enzymes such as pancreatic lipase or intestinal lactase, which are necessary for digestion, inadequate secretion of bile salts, and inadequate reabsorption of bile in the ileum. Malabsorption is a result of mucosal disruption caused by gastric or intestinal resection, vascular disorders, or even intestinal disease. Pancreatic exocrine insufficiency causes malabsorption associated with impaired digestion. Your pancreas doesn't produce sufficient amounts of enzymes in this disease process, and these enzymes that digest protein, carbs, and fats can break down into components that can be easily absorbed by the intestines. But when we have this insufficiency, they are not able to do that. So the pancreatic enzymes like lipase, amylase, trypsin, and chymotrypsin are required for digesting proteins, carbs, and fats. But with pancreatic insufficiency, we have a deficit or deficiency of that production. So the enzymes in the pancreas are not enough. Causes of insufficiency include chronic pancreatitis, carcinoma of the pancreas, resection of the pancreas, or cystic fibrosis. The absence of pancreatic bicarb in the duodenum and jejunum will cause your acidic pH to worsen maldigestion by preventing that activation of pancreatic enzymes that are present. That large amount of fat that patients are eating is the main problem. So what we're going to see is steatorrhea, which is fat in the stool, and weight loss. These are the most common signs that you have pancreatic insufficiency. You can also check your lipase, and you can also check to see your other pancreatic enzymes as well. But the steatorrhea or the fatty stools are going to be, in addition to weight loss, are going to be the telltale signs. Some patients will have lactase deficiency. Deficient lactase production in the brush border of the small intestine will inhibit the breakdown of lactose, and it prevents lactose absorption. So this will cause osmotic diarrhea. A lactase deficiency is a deficiency of the disaccharides at the villus brush border. It's caused by a genetic defect with the single enzyme. Usually it's lactase that's lacking. Lactase deficiency will inhibit that breakdown of lactose, which is the milk sugar, into monosaccharides, and then prevents lactose digestion and absorption across your intestinal wall. It's mostly common in patients of Latino descent, Native Americans, and Blacks, and it usually doesn't develop until adulthood. We also have congenital lactase deficiency, which will cause watery diarrhea in your breast milk or lactose-containing formulas in infants. Lactase expression is lost between adulthood in adult-type lactose intolerance, or we have secondary or acquired lactase deficiency that is caused by diseases of the intestines like celiac disease, enteritis, and bacteria overgrowth. The undigested lactose remains in the intestines where the bacterial formation causes formation of gases. That undigested lactose also increases the osmotic gradient in the intestines, causing irritation and osmotic diarrhea. So someone that has lactose consumption with lactase deficiency, meaning they have this lactase deficiency but they still want to consume lactose, will complain of bloating, cramping, diarrhea, and flatulence. It's diagnosed by testing lactose malabsorption and lactose tolerance. So we can avoid milk products and adhere to a lactose-free diet to relieve some of these symptoms. And that lactase enzyme replacement is also an option as well. With bile salt deficiency, this can cause fat malabsorption and steatorrhea, which again is fatty stools. And bile salt deficiencies can also result from inadequate secretions of bile, excessive bacterial deconjugation of the bile, or impaired reabsorption of those bile salts. And this usually occurs in ileal diseases. So what happens with bile salt deficiency? We have conjugated bile salts, which we need to emulsify and absorb all those fats. It has to help with the digestion of the fats. This happens in the small intestines. Those bile salts are conjugated in the bile, synthesized from cholesterol and secreted from the liver. And when that bile enters the duodenum, the bile salts will aggregate with the fatty acids, the monoglycerides, and form micelles. Now, micelle formation makes fat molecules more soluble, and it allows them to pass through the unstirred layers at that brush border of the small intestinal villi. A minimal concentration of bile salts, termed the critical micelle concentration, is required to allow micelles to form. Therefore, Conditions that will decrease that production of bile results in a decreased formation of micelles and fat malabsorption. So, advanced liver disease, because this will decrease absorption of bile salts. Obstruction of the common bile duct decreases the flow of bile into the duodenum, or if you have intestinal stasis, which is just the lack of motility. This will permit overgrowth of intestinal bacteria and deconjugate your bile salts. Any disease or resection of the ileum will prevent reabsorption and recycling of bile salts as well. So, what are the clinical manifestations of bile salt deficiencies? Well, it's really related to poor intestinal absorption of your fat and your fat-soluble vitamins, like A, D, E, and K. You'll also see increased fat in your stools, which leads to diarrhea and decreases your plasma protein. So that loss of the fat-soluble vitamins, again, vitamins A, D, E, and K, and their effects will cause deficiencies, and you can see them here. Vitamin A, night blindness. Vitamin D, decrease in calcium absorption, bone pain, osteoporosis, and fractures. If you have a deficiency in vitamin K, you have prolonged prothrombin time. You will have increased risk for purpura petechiae, bleeding. And vitamin E, it's really uncertain how this deficiency really affects people, but it could cause testicular atrophy and neurological deficits in children. Now we're moving on to lower GI, starting with inflammatory bowel disease, and it will be really important for you to distinguish well the difference between ulcerative colitis and Crohn's disease, both under the umbrella of inflammatory bowel disease. Both ulcerative colitis and Crohn's disease are chronic relapsing inflammatory bowel disorders that are genetic, but they can also be caused by environmental factors, alterations in the epithelial barrier functions, and altered immune reactions to intestinal flora. And you can see here the difference side by side between Crohn's disease and ulcerative colitis. Now, with Crohn's disease, it can happen at any point of your GI system, and what you will see is skip lesions and transmural inflammation going all the way through the linings. With Crohn's disease, our patients will have strictures, linear ulcerations, and fissures. The large intestines usually are associated to pseudopolyps, and there is a continuous colonic involvement beginning in the lower GI rectum area. It's actively, you will see superficial ulcerations throughout this region, but inactively you see atrophy of the colon area. So those are just the general differences overall, but as you begin to think about ulcerative colitis and Crohn's disease, again, make sure you can understand the differences and the similarity in the fact that they both are inflammatory disorders. This slide here can also show you the differences as well. I want you to pay attention here again that Crohn's disease can happen anywhere throughout the GI tract, where ulcerative colitis, again it's in the name, will happen starting from the sigmoid colon, and it is continuous, where again Crohn's disease, you can see the skip lesion, so it can be throughout. So we'll first talk about ulcerative colitis in a little bit more detail. Now, the primary lesions of ulcerative colitis, again, starts with inflammation at the base of the crypt of Lieberkühn, which is where it involves the rectum, or we will see proctitis, inflammation at that rectal area. And it extends proximally into the entire colon, and this is when we call it pancolitis. Now, the lesions are limited just to the mucosa. They're not transmural like we see in Crohn's disease, and they don't involve skip lesions, which we see in Crohn's disease. This inflammation will infiltrate and release inflammatory cytokines, activate neutrophils, lymphocytes, and plasma cells, macrophages, eosinophils, and mast cells. So lots of inflammatory reaction. The activated macrophages will contribute cytokines that cause fever, and in the acute phase response, your patient will complain of fever. The inflammation will damage the epithelial mucosal barrier only, but it will leak fluids into your gut. Now, there are situations where you have milder inflammation, where the mucosa is just hyperemic and edematous. And if you were to look at it with perhaps with the colonoscopy, it would appear dark red and velvety just in the mucosa. Remember, it's not transmural, it's not going through all the layers. But in severe inflammation, the mucosa will actually become hemorrhagic, and you will see the small erosions form, and they will actually coalesce into colonic ulcers. Abscesses may form, and this will occur in the crypts of the colonal lining. You are at risk for necrosis, and ragged ulceration of the mucosa will ensue with the formation of granulation tissue. This edema and thickening of the muscularis mucosa can narrow the lumen of the involved colon. Someone with chronic disease, you will see the pseudopolyps. Okay, so these are inflammatory polyps that develop in the colon, and it's from rapidly regenerating epithelial cells. Now, in contrast, we'll talk about Crohn's disease. And Crohn's disease, we have granulomatosis colitis, ileocolitis, or regional enteritis. And it involves an idiopathic inflammatory disorder. And this is what distinguishes it from ulcerative colitis. It can happen again any part of the GI tract from the mouth to the anus, and you have the skip lesions, which are the inflamed areas mixed with uninflamed areas throughout your intestinal tract. You will also have non-caseating granulomas, fistulas, and deep penetrating ulcers because it's transluminal and it will penetrate through all the layers. The distal small intestines and the proximal large intestines are important areas because these are the most common sites that are affected by Crohn's disease. Again, it's the small intestines and the proximal large colon. You can see that in the inflammatory lesions, they will begin in the intestinal submucosa and then spread discontinuously through the transmural involvement. This is what defines a skip lesion. The ascending colon and the transverse colon are the most common sites of the disease. However, both the large and small intestines can be involved, particularly in the ileum. Now, one side of the wall might not be infected, but the other one can be infected. And the progression of the disease involves neutrophil infiltration of the crypts. It can result in abscess formation, crypt destruction, can produce also longitudinal and transverse fissures that will extend the inflammation into your lymphoid tissues. Fistulas may form in the perineal areas between the loops of the intestines or extend in the bladder, rectum, or vaginal area. Strictures can also develop and promote more obstruction, and a patient that smokes can increase the risk of Crohn's disease and relapsed, heightened symptoms. The symptoms are very similar to ulcerative colitis. You might also see anemia resulting from the malabsorption of B12 and folic acid, so a pernicious type anemia in patients with Crohn's disease. With microscopic colitis, this is another type of inflammatory bowel disease, a little bit less common. It involves either mucosal lymphocytic infiltration or a thickened subepithelial collagen layer. And the most common symptom is watery diarrhea. The risk factors are those patients that are 50 or older, female. You will have some weight loss. There won't be any abdominal pain. And they probably are using a proton pump inhibitor or an NSAID. They might have celiac disease or maybe a smoker. Now, when you look at the mucosa, it's going to appear normal, but there are two histologic forms, the lymphocytic and the collagenous. The lymphocytic will show more than 20 intraepithelial lymphocytes per 100 epithelial cells, and that's how it is diagnosed. The collagenous colitis is characterized by a thickened subepithelial collagen band. They will show alterations of the vascular mucosal pattern and the mucosal nodularity. We don't know why, but we can see them in histologic studies. Questions about irritable bowel syndrome and inflammatory bowel disease commonly get mixed up, so be very careful when you're reading your questions. IBS is characterized by abdominal pain with altered bowel habits, and it's symptom-based. There is an alteration in your brain-gut axis, your gut microflora, your immune responses in the gut, and the neuroendocrine cell functions there. There might be a genetic susceptibility to irritable bowel syndrome, and epigenetic factors can contribute to the symptoms. You'll have intestinal hypersensitivity, inflammation. There may be increased permeability as well. And the symptoms caused by alterations in motility and secretion are the most common. Females are affected more than males, and usually it's younger patients as well. Irritable bowel syndrome is associated with anxiety, depression, and an overall reduced quality of life because your bowel habits cannot be easily predicted. It is pathophysiologically caused by an unknown reason, but there are some mechanisms that have been proposed. So going back to that brain-gut axis, it can be related to pain and the dysregulation of the bidirectional brain-gut axis. So you will have visceral hypersensitivity or hyperalgia, particularly with distension of the rectum, but it can occur in other areas of the gut as well. And usually this happens in up to 40% of patients with IBS. And it's unknown, but it can originate in the peripheral, enteric, or the central nervous system. That mechanism of bidirectional brain-gut axis, or the alterations in gut or central nervous system processing of the gut nociceptive information. So spend a little bit more time looking into that brain-gut axis. Post-inflammatory, it could be alterations in gut microbiota, food allergies, intolerances, and psychosocial factors that all feed into irritable bowel syndrome, as we discussed earlier. The manifestations are usually lower abdominal pain, discomfort, and bloating. And to get rid of the symptoms, usually you will have relief after a stool, and usually the symptoms will not interfere with your sleep. There isn't a particular cure as opposed to just trying to manage the symptoms, and the treatment is individualized to the patient. So if you can figure out what is causing irritable bowel syndrome in the first place, you might be able to address that cause. We're moving now into diverticular disease of the colon. So be aware of the differences in the terminology of diverticulosis versus diverticulitis. Now, a diverticula are the herniations of mucosa through the muscle layers of the colon's wall, especially in the sigmoid colon area. When someone is said to have diverticulosis, this is an asymptomatic disease process. When we talk about someone that has diverticular disease, it could be diverticulosis or diverticulitis. So at the point of diverticulosis, there are no symptoms, but you will still have those herniations or sac-like outpouches of mucosa through the muscle layers of the colon wall. Once someone has diverticulitis, it's because that diverticulosis has become inflamed. Okay, so it's the inflammatory stage of diverticulosis. The cause of diverticular disease is unknown, but there are approximately 300,000 or more hospital admissions every year related to diverticular disease. And there are some predisposing factors worth mentioning. The older you are, the more prone you are to diverticular disease. There is a genetic predisposition, but also obesity, smoking, your diet, and lack of physical activity can also play into diverticular disease. Medications like aspirin and NSAIDs can also put you at more risk as well. Lack of dietary fiber may or may not contribute to diverticular disease. There are some studies that say yes, some that say no. So in terms of the overall pathophysiology, a diverticula can exist anywhere in your GI tract, but the common sites are in the left colon area. And this is more common in Western countries, although the right colon area can be a place for diverticula as well, and this is more prevalent in Asian countries. They rarely occur in your small intestines, and they're associated with an increased intercolonic pressure, also abnormal neuromuscular function, and alterations in intestinal motility. The diverticula will form a weak point in your colon wall where your arteries penetrate the tunica mucularis to nourish that mucosal layer. Because of this, if there's complications and complicated diverticulitis, you are at risk for abscess, fistula, obstruction, bleeding, or perforation. And the symptoms of uncomplicated diverticular disease can actually be vague or even absent, like I talked about. So it's not until you have diverticulitis that you will see a presence of symptoms. Now, the colonic mucosa will herniate through the smooth muscle layer, and you will see thickening of both the circular and the longitudinal muscle surrounding the diverticula. Increased collagen and elastin deposits, not muscular atrophy, is associated with wall thickening and contributes to even an increased interluminal pressure and further cause worsening herniation. If you habitually consume a low residue diet, it will reduce your fecal bulk, and this will reduce the diameter of the colon. So this will cause your wall pressure to increase as the diameter of the cylindric structure will decrease. That pressure within the narrow lumen can increase so much that it can cause local ischemia and rupture the diverticula. Appendicitis is the inflammation of the variform appendix, and you can see it's coming off the apex of the cecum area. And usually it's caused by obstruction, foreign bodies, or infection, but these are just possible causes, not anything that we can quite verify. It is a very common surgical emergency of the abdominal area, and usually it happens with patients between 10 and 19 years old, but it can happen with patients of all ages, and it occurs very frequently here in the US. About 10 per 10,000 people are affected. Usually if you have a family member that's had appendicitis, you're at a higher risk for appendicitis as well. So going into the actual pathophysiology, it is a controversial one. Again, talking about obstruction of the lumen with stool, tumors, foreign bodies, these can increase that interluminal pressure, cause ischemia, bacterial infection. Inflammation is the most common theory, but again, it is a theory. The obstructed lumen doesn't allow drainage of the appendix, and The mucosal secretions will continue, that interluminal pressure will increase, and what they think is the result will be a pressure decreasing mucosal blood flow, and the appendix becomes hypoxic in this circumstance. The mucosa ulcerates, promoting bacterial or other microbial invasion, and will further increase inflammation, further increase edema, and will involve the distal or entire area of the appendix. What we don't want to happen is gangrene, and this will develop from thrombosis of that luminal blood vessel followed by perforation of the appendix. The appendix can harbor bacteria that contribute to the development of appendicitis overall. With mesenteric vascular insufficiency, this is rare. It happens about 2 to 3 cases per 100,000 people, and it involves the artery system, the venous system. It can be occlusive or non-occlusive. Now, there are 3 branches of abdominal aorta that supply blood flow to the stomach and intestines. We have the celiac artery, the superior and the inferior mesenteric arteries. The inferior mesenteric veins will drain into the splenic vein, and the superior mesenteric vein combines with the splenic vein to form the hepatic portal vein. The mesenteric venous thrombosis is the most common cause of someone with mesenteric vascular insufficiency. So, what are the risk factors? We have hypercoagulability, endothelial injury, malignancies, someone that has right-sided heart failure, DVT, acute mesenteric artery insufficiency. These are more commonly actually in our elderly patients. If there is a significant reduction in mucosal blood flow to the large and small intestines, we can actually cause mesenteric venous thrombosis. And it could also be that there is a pre-existing dissected aortic aneurysm or arterial thrombi that puts you at risk for mesenteric venous thrombosis. However, this is less common than chronic mesenteric ischemia. This is secondary to cardiac alterations, someone that has atherosclerotic stenosis, which is the most common of the reasons, congenital heart failure, acute MI, or just any situation where it will decrease your arterial blood flow. Remembering again that chronic mesenteric ischemia is rare, but if it does occur, it's secondary to these type of alterations. Now, some patients will complain of cramping abdominal pain when ischemia develops. This is called abdominal angina, and it's a cardinal symptom of this disease process. Some people will suffer from significant weight loss because they stop eating. When they stop eating, it controls the pain. Progressive vascular obstruction will eventually cause continuous abdominal pain, will cause necrosis of your intestinal tissue, and it can actually precipitate an acute mesenteric insufficiency. But we are worried, furthermore, by reperfusion injury, and this is related to reactive oxygen metabolites and inflammatory mediators that will cause tissue damage following the revascularization of that area. How do we diagnose this? Whether it's acute or chronic mesenteric ischemia, it's really based on the clinical manifestations, your lab findings, your imaging studies. You might even hear bruit, which is a sign that there's a partially occluded artery in that area. The treatments are really aggressive: rehydration, the use of antibiotics, anticoagulants, vasodilators, and we're trying to inhibit that reperfusion injury that we talked about. Now, there can even be surgical techniques like endovascular surgery to remove the necrotic tissue. They'll try to repair any vessels that were sclerosed, and the main objective is really to revascularize that affected tissue. If there is an acute mesenteric ischemia, surgical intervention is appropriate. It's an emergency and there is a very high mortality risk. So early diagnosis is the key in this situation. Now we're going to move on to alterations in the GI accessory organs. And as we move on to our accessory organs in the GI system, please review the structure and function of these organs, particularly the liver and the spleen. In terms of alcoholic liver disease, these are groups of diseases that are related to the toxic effects of alcohol and someone that has a coexisting liver disease. So alcoholic fatty liver, alcoholic steatohepatitis, or alcoholic cirrhosis. And you will see that these patients have anorexia, nausea, jaundice, edema that develop with advanced fatty infiltrations in the liver or the onset of alcoholic steatohepatitis. Now, alcoholic cirrhosis is a complex process that begins with fatty infiltrations, which we are calling hepatic steatosis. The fat deposition of triglycerides within the liver hepatocytes is primarily caused by lipogenesis and decreased fatty acid oxidations of the hepatocytes. And it's the only type of cirrhosis associated with a hepatic fat. Non-alcoholic fatty liver disease, or non-alcoholic steatohepatitis, is infiltration of hepatocytes with fat, but it's primarily in the form of triglycerides. It occurs in the absence of alcohol, and it's associated with polygenic susceptibility, obesity, high levels of cholesterol and triglycerides, and unfortunately, we're seeing this in children now as well. Patients with metabolic syndrome, type 2 diabetes, or anyone with alterations in the gut microbiome are at risk for non-alcoholic fatty liver disease. It's the most common chronic liver disease in the US, and some patients with non-alcoholic fatty liver disease will develop non-alcoholic steatohepatitis, or what we call NASH. It's the most severe form that progresses into cirrhosis. It can progress into end-stage liver disease and increase the risk of hepatocellular carcinoma. Now, NASH is difficult to distinguish from alcoholic-induced liver disease, and it will require a biopsy to do so. Non-alcoholic fatty liver disease is usually asymptomatic, and it can remain undetected for years. So how would we treat someone if it is found? Or how do we counsel someone to prevent non-alcoholic fatty liver disease? Really, it goes down to lifestyle modification, diet, and exercise. There are some pharmacotherapies like insulin sensitizers, vitamin E, which is an antioxidant, and lipid-lowering drugs can also be considered to help decrease the progression of non-alcoholic steatohepatitis. Once it turns into cirrhosis and end-stage liver disease, the only option at that point is a liver transplant. And if we're walking through the progression of non-alcoholic fatty liver disease, we can start with this side here on the left in green, liver inflammation. That will cause pain and fever, nausea, vomiting, anorexia, and fatigue. The liver fibrosis and scarring can happen, which will lead to portal hypertension. And that portal hypertension puts pressure, causing ascites, edema, splenomegaly. You'll see varices, like esophageal varices or hemorrhoids. And going back to splenomegaly for a second, when you have an enlarged spleen, you're more at risk for anemia, thrombocytopenia, and leukopenia because you have sequestration of those cells, causing them not to be in good supply in the rest of your body. With liver necrosis, we'll see decreased bilirubin metabolism. So if metabolism bilirubin is delayed, then you will have hyperbilirubinemia, resulting in jaundice. Decreased bile in your GI tract will lead to light-colored stools as a symptom. And if you have decreased vitamin K absorption, you have bleeding tendencies. And lastly here is increased urobilinogen, or bilinogen, will show in the patient's urine, and it will cause it to be dark. So all of this is occurring because you have decreased liver function. Also, your liver, if it becomes necrose, you will have decreased hormonal metabolism. It will increase androgens and estrogens, leading to gynecomastia, loss of body hair. You'll have dysfunction in your menstrual cycle, spiderangiomas, polymer erythema, and increased ADH and aldosterone can lead to edema. So increased antidiuretic hormone. We also have a decrease in metabolism of proteins, carbs, and fats, leading to hypoglycemia. Decreased plasma proteins will lead to ascites and edema. There are other biochemical alterations. So this is what you would see on labs: elevated AST and ALT, elevated bilirubin. You'll have low serum albumin because of the decreased plasma protein. So you'll see ascites and edema, low serum albumin. Prolonged prothrombin time. This is related back to the splenomegaly, leading to thrombocytopenia. Elevated alkaline phosphatase. Your liver failure will lead to hepatic encephalopathy if not corrected, hepatic coma, and lead to death. So non-alcoholic fatty liver disease is an important disease process to understand. It, again, may go undetected for years, but can ultimately lead to death. Now, liver cirrhosis is irreversible. It's an inflammatory fibrotic liver disease which occurs when the biliary channels are obstructed. It causes portal hypertension, and you can see that there can be many causes. Now, many disorders like alcohol abuse or even hepatitis C infection can be among the causes, and even non-alcoholic fatty liver disease. But of those causes, alcohol and hep C infection are the most common reasons someone would have cirrhosis. And it's not clearly understood, but you will notice some structural changes that result from injuries from alcoholism or hep C virus. Fibrosis is a consequence of your Kupffer cells, which are your liver macrophages, being activated with the release of inflammatory mediators, reacting oxygen species and growth factors, and activation of fibrogenic hepatic stellate cells. So all of this happening will cause chaotic fibrosis and obstruct your biliary channels and your biliary blood flow. This is primarily what is leading to jaundice and portal hypertension. Now, new vascular channels will form, and they're forming shunts so that you can get blood from the portal vein to bypass to the liver. But this is going to contribute to further portal hypertension, metabolic alterations, and even accumulation of deadly toxins. The process of regeneration is disrupted altogether because you'll have hypoxia, necrosis, atrophy, and ultimately it will lead to liver failure. So those fibrosis bands and regenerating nodules will overall distort the architecture of your liver and cause it to become very bumpy or cobbly. The liver may be larger or smaller than normal, but it's going to feel very different. It's usually firm when you palpate it, and you can feel kind of the bumps and the ridges on it. Cirrhosis ultimately progresses very slowly over a period of years, but its severity and rate of progression depends on what the overall cause was in the first place. Again, those overall complications are going to be jaundice, portal hypertension, ascites, hepatic encephalopathy, varices, GI bleed. You might have hepatorenal syndrome, hepatopulmonary syndrome, and portal pulmonary syndrome. Very common in some respect to what is happening in non-alcoholic fatty liver disease because it can progress to cirrhosis. So if you have a failure in your hepatocytes, your albumin synthesis will decrease. Again, we have low albumin, you will see edema. You'll have decreased capillary onconic pressure, leading to a decrease in your effective plasma volume and lower your renal blood flow perfusion. This, in addition to altered metabolism, will increase your renin, aldosterone, and antidiuretic hormones. It increases your renal absorption of sodium water, which will cause ascites. Additionally, the portal hypertension is also leading to ascites. You will have increased lymph production, you'll have arterial vasodilation, and increased capillary filtration pressure, all leading back to ascites. The translocation of your gut bacteria, bacterial peritonitis, will occur and increases capillary permeability as well, increasing your risk for ascites. Let's talk about portal hypertension just a little bit more so you understand the implications. Portal hypertension is defined by the coexistence of high blood pressure in the portal venous system caused by intrahepatic or post-hepatic resistance to portal blood flow. You will see varices in the lower esophagus, the stomach, the abdominal wall, and the rectum, as well as splenomegaly. Now, when we talk about hepatopulmonary syndrome, this is going to be manifested with shortness of breath, hypoxemia, which is caused by the vasodilation in the lungs of patients with liver disease. We talked about portal pulmonary syndrome. This is when both portal hypertension is occurring plus pulmonary hypertension is occurring. Now with portal hypertension, we have abnormally high blood pressure in the portal venous system because of the resistance to portal blood flow. That pressure in the system is normally 3 to 5 millimeters per mercury, but in portal hypertension, it can increase above 5 millimeters per mercury. So there's an elevation of hepatic venous pressure that's occurring. Now, it's caused by disorders that obstruct or impede your blood flow overall. And so we already talked about how cirrhosis can do this. Let's talk about the intrahepatic and the post-hepatic causes. When we talk about intrahepatic, this means that there is vascular remodeling with intrahepatic shunts, thrombosis, inflammation, or fibrosis of the liver, or cirrhosis. And post-hepatic, this is when the hepatic vein, a thrombus, or cardiac disorder impairs the ability to pump to the right side of the heart. And this is going to cause your blood to back up into that system, increasing the pressure in the portal system. The most common cause of portal hypertension is fibrosis and obstruction that's caused by cirrhosis of the liver. Ascites is the accumulation of protein-containing acidic fluid within the abdomen. And understanding ascites will help you to understand the overall pathophysiology of what's happening with cirrhosis and other liver diseases like alcoholic or non-fatty alcoholic liver disease. The most common cause of ascites is high blood pressure in the veins that bring blood to the liver, which we call portal hypertension. And this is, again, usually due to cirrhosis. We have to understand onconic or colloid osmotic pressure. And this is a form of osmotic pressure exerted by proteins in the blood plasma or your intestinal fluid. In contrast, hydrostatic pressure is the force generated by the pressure fluid within or outside of the capillary or the capillary wall. So, with ascites, there's a collection of free fluid within the peritoneal cavity caused by an increase in hydrostatic pressure from the portal hypertension. There's a collection of plasma protein in the peritoneal fluid, which reduces that amount of circulating plasma protein in the blood. And when we have this decrease, it's going to be combined with the inability for the liver to actually produce albumin because your liver cells are impaired. The serum colloid osmotic pressure, therefore, is decreased because we need albumin to increase osmotic pressure. So what is the net result? That fluid is going to shift from the vascular system into the abdomen, and this is what we call third spacing. The result is the patient will have hypovolemia and edema at the same time. Hypovolemia because we're pulling out the fluid in the vascular system, and edema because we're moving all that fluid into the abdominal space. Now, again, to sum it up, the overall idea is that there's this overflow theory. Portal hypertension and reduced serum albumin can cause capillary hydrostatic pressure to exceed the capillary osmotic pressure, and that's why we can't keep out what we need to keep out and keep in what we need to keep in. That portal hypertension will increase your capillary hydrostatic pressure into the intestinal wall, causing that fluid to what we call weep into the peritoneal cavity. That, in addition to reduced capillary and conic pressure, will add to the fluid shift. The resulting decrease in affected circulating plasma volume will activate antidiuretic hormone to release, and the renin-angiotensin-aldosterone system will stimulate the kidney to retain water and sodium, leading to intravascular fluid overload. Now, there's also the peripheral arterial vasodilation theory. And this is a synthesis of overflow and underfill theories, and it's the most accepted theory of what causes ascites. This theory proposes that the circulating nitric oxide and carbon monoxide that causes that vasodilation. The decrease in systemic vascular resistance will overcome the compensatory cardiac output. Stimulation of baroreceptors will activate renal sodium retention through activation of your renin-angiotensin-aldosterone system, or RAS. It will increase the sympathetic tone, secrete antidiuretic hormone, and fluid retention. What you're going to see overall is an increase in abdominal distension, abdominal girth, or like the measurement, and weight gain. The only way to remove this free fluid is through paracentesis, which will extract the fluid from the peritoneal cavity. Hepatic encephalopathy can occur if cirrhosis progresses to the point that it is causing these other conditions that we've talked about, the portal hypertension, the ascites, and we're not able to regulate the liver disease. It will in turn move forward into hepatic encephalopathy, which is a neurologic syndrome, which you will see marked changes in behavior, cognitive function, motor function, and it's due to all the biochemical alterations affecting the neurotransmission. Liver dysfunction and the collateral vessels that shunt blood around the liver to the systemic circulation will permit neurotoxins to move and be absorbed into your GI tract, which will then accumulate and circulate to the brain. So think of inflammatory cytokines, short-chain fatty acids, serotonin, tryptophan, and other false neurotransmitters can feed in to hepatic encephalopathy. The most hazardous substances are end products of intestinal protein digestion, particularly ammonia. And ammonia cannot be converted to urea by the diseased liver. The digestion of blood from leaking or ruptured varices, because of the portal hypertension and the other things that are occurring in this process, will activate ammonia-forming bacteria in the colon. And this ammonia will reach the brain eventually and metabolize to glutamine. With osmotic disturbances and alterations in your cerebral blood flow, it will interfere with neurotransmitters and actually cause astrocyte edema. It will also cause oxidation in the brain. The permeability of your blood-brain barrier will increase, causing vasogenic edema. And all of this is contributing to astrocytes that will swell, causing overall brain edema, intracranial hypertension, and you will have an excessive amount of GABA, which is gamma aminobutyric acid. This is an inhibitory neurotransmitter from a benzodiazepine-like compound from the intestinal flora, and it contributes to reduced levels of consciousness. Infection, hemorrhage, inflammation. We will also have electrolyte imbalances, sedatives, analgesics. These can all precipitate your patient into a stupor and a coma in the presence of liver disease. Let's review again simply the hepatic encephalopathy pathophysiology. Ammonia accumulates, moves to the brain, metabolized by glutamine. The osmotic disturbances will increase and alter cerebral blood flow, interfering with neurotransmitters, causing cytotoxic edema and oxidation. Your blood-brain barrier becomes more permeable, which will increase, leading to brain edema, intracranial hypertension, and you'll have excessive amounts of GABA. This is going to contribute to the lower levels of consciousness. We're also worried about infection, hemorrhage, inflammation, electrolyte imbalances, sedatives, analgesics, all precipitating to coma. There are both early and late symptoms of hepatic encephalopathy. Early symptoms have to do with subtle changes in personality, memory loss, irritability. Maybe they are lethargic or having difficulty sleeping, where the late symptoms are more severe. Confusion, they become disoriented to time and space. You might even see asterixis, which is the flapping tremors of the hands. Their speech becomes slower. You might see changes in movement like bradykinesia, stupor, convulsions, and eventually coma. Jaundice is caused by hyperbilirubinemia, and sometimes it's called icterus, and it can be obstructive or hemolytic. With obstructive jaundice, it's something that is either extrahepatic or intrahepatic. When you think of extrahepatic, it's usually a gallstone or tumor inflammation that's blocking conjugated bilirubin from moving into the duodenum, and it'll just accumulate and enter the bloodstream and cause hyperbilirubinemia and jaundice. With intrahepatic objective jaundice, this is the disturbance in the hepatocyte function itself, where there's an obstruction there in the bile caniculi. The uptake, conjugation, and excretion of bilirubin is affected with elevated levels of both conjugated and unconjugated bilirubin. Now, with hemolytic jaundice, we have prehepatic jaundice, and we have excessive destruction of red blood cells, or either the absorption of hematoma caused by a hemolytic jaundice, or increased unconjugated bilirubin being formed through metabolism of the heme component of destroyed red blood cells. And this increase in formation exceeds the conjugation of the liver, or the ability for your liver to conjugate. So it causes blood levels of unconjugated bilirubin to rise up. That decrease of bilirubin uptake and conjugation will cause unconjugated hyperbilirubinemia. And as this occurs, it could happen due to reaction to some drugs, or it could be a genetic disorder like Gilbert syndrome, which is an inherited autosomal dominant deficiency of a specific enzyme that's required to be used in hepatic uptake of unconjugated bilirubin. The cause of jaundice, you can see, can be summarized into either a hepatobiliary mechanism or a hematologic mechanism, which you can see in both of these different pathways. Acute liver failure is a rare clinical syndrome that results in severe impairment of the necrosis of the liver cells without any type of pre-existing liver disease or any progression to cirrhosis. Sometimes it's called fulminant liver failure. Acetaminophen overdose is the leading cause of acute liver failure in the US, and it can occur with concurrent liver disease like acute or chronic liver failure, including complications of hepatitis, particularly a Hep B or a Hep C infection, and compounded by infections with other viruses and metabolic liver disorders as well. In acute liver failure, you'll have edematous hepatocytes and patchy areas of necrosis and inflammation that disrupts the parenchyma. The death of hepatocytes caused by viral or toxic injury or immunologic and inflammatory damage with necrosis or apoptosis will occur as well. Typically, acute liver failure will develop within 6 to 8 weeks after the initial symptoms of viral hepatitis or some type of metabolic liver disorder like Wilson's disease. It can happen within 5 days to 8 weeks of acetaminophen overdose. Anorexia, vomiting, abdominal pain, and progressive jaundice are your initial signs. Afterwards, you're going to see ascites, GI bleeding, in addition to those initial signs. If not halted, hepatic encephalopathy can be manifested. You'll see first lethargy, altered motor functions, and then as it progresses to late stage symptoms, you can see coma too, related to cerebral edema, ischemia, and brainstem herniation. If you get liver function tests, they're going to show elevations in both conjugated and unconjugated serum bilirubin, serum transaminases, and blood ammonia. Your prothrombin time, or PTT, is going to be prolonged as well. Remembering that both renal failure and pulmonary distress can occur in addition to that liver failure. Simply put, hepatitis can be found in 5 types, A, B, C, and D, and they're a group of diseases that are systemically viral diseases affecting the liver. And there can be a spectrum of manifestations that range from the absence of symptoms altogether to fulminating hepatitis with rapid onset of liver failure and liver coma. Let's talk about hepatitis A first. And the usual transmission, again, is a fecal-oral route through contamination of food or contamination of water. And it can be spread very quickly through infected blood as well, and high-risk sexual behavior. Person-to-person spread is more likely to occur in institutional care settings like long-term care facilities where there's contact between clients or patients and their caregivers who may not be vaccinated. But usually this disease is going to spread readily in crowded, unsanitary conditions, usually through contaminated food and water. With hepatitis B, this is a parenterally and sexually transmitted disease with 8 genotypes, A through H, and the genotypes vary between geographical location, progression of the disease, and the treatment response. Most of the time, the patients that are going to have the highest risk of exposure or have less resistance to hepatitis B virus are those that are immunosuppressed, taking immunosuppression drugs. They are the ones that are on hemodialysis or have had multiple blood transfusions. Those that have high risk sexual behaviors or multiple sexual partners, share needles, syringes, or any other drug equipment, these are all patients that are going to have a great risk of exposure or less resistance to HBV. Additionally, infants born to infected mothers also will have greater risk for exposure. It's very common that there would be a co-infection with hepatitis C, hepatitis D, and HIV because they all share the same route of transmission. With hep C, this is parenterally transmitted as well with 10 genotypes, and it involves intravenous drug users, and those are the ones that are going to have a high incidence of hepatitis C. Also, hepatitis C is associated with a high incidence of HIV infection as well. And those patients with hepatitis B increase the risk for hepatitis C. And about 80% of cases, hep C cases, will develop into chronic liver disease. Persistent infection with recurring acute symptoms and elevated liver enzymes really represents a clinical presentation, but often hepatitis C is underdiagnosed because there's no symptoms at all. The progression of the disease, however, can lead to cirrhosis, which is the most common cause of hepatocellular carcinoma in the US and the most common cause of liver transplant worldwide. Hepatitis D is often occurring as a co-infection with hepatitis B. Hepatitis D has been shown to suppress the replication of hep B virus, and parenteral drug users have a high incidence of hepatitis D infection. You can see that correlation to hepatitis B again because the route is the same. Hepatitis E is also transmitted by a fecal oral route, usually by the way of contaminated water or uncooked meat, usually found in Asian countries and African countries more often than other places in the world. It's more prevalent with adults that have the highest mortality in pregnant women and immunosuppressed individuals. You can see here on this slide, I've shown just other schematics that you can use to help determine the difference between the Hep B, C, D, and E viruses, how they are transmitted, and what type of screening you can use, and what type of treatments are available. Important to understand the phases of viral hepatitis. We have the incubation period. This is the period between when you receive the virus into your body, you're introduced to your body to when there are symptoms. Then we move into the prodromal period, the icteric, and the recovery period. In the prodromal period, sometimes also called the pre-icteric period, this is when hepatitis begins about 2 weeks after the exposure and ends with jaundice. You'll also see fatigue, anorexia, malaise, nausea, vomiting, headache, cough, low-grade fevers. These can all happen in this prodromal phase, and we call them prodromal symptoms of hepatitis. And these will all proceed to the onset of jaundice. In the icteric phase, this is the jaundice phase. So prodromal is leading all the way up to jaundice, which is icteric. The icteric phase begins about 1 to 2 weeks after the prodromal phase and lasts about 2 to 6 weeks. And those who develop chronic hepatitis B infection, they don't become jaundice, so they may not be diagnosed during this phase. Hepatocellular destruction occurs here, and intrahepatic bile stasis can cause this jaundice to occur. And jaundice, another name for that, again, is icterus. The urine can increase in color, so it becomes darker. The stools can become clay colored before the onset of jaundice from conjugated hyperbilirubinemia. In this phase, this is the actual phase of illness. So think prodromal, meaning before the actual illness, and then the recovery phase is after the icteric phase, which is the illness phase. In this phase, the liver can be enlarged, smooth, and tender. You can actually, if you percuss over the liver, it can cause a lot of pain during the icteric phase. You also will have a lot of GI and respiratory symptoms subsiding, but then the fatigue and the abdominal pain just persists and becomes more severe. You'll see, because of cholestasis, lighter color stools. And if you were to take blood levels of bilirubin, the serum levels would show 5 to 10 milligrams per deciliter. Jaundice can last for 2 to 6 weeks and even longer. You might even notice a difference in your PTT. That prothrombin time may be prolonged if you have serious symptoms and the icteric phase is more advanced. In the recovery phase or the post-icteric phase, so after the disease, you have the resolution of jaundice, and this happens about 6 to 8 weeks after the exposure. The liver may still be enlarged and tender, but most of the symptoms are starting to diminish at this time. Most cases, the liver function tests will result in normal levels within 2 to 12 weeks after the onset of jaundice or the onset of the icteric phase. Now, chronic hepatitis may begin at this point, and it's associated with Hep B, Hep C, and Hep D infections. When you have chronic active hepatitis, which is a persistence of the clinical manifestations in the liver inflammation after the acute stage, you can get liver function tests that can remain abnormal for as long as 6 months. Now, chronic active Hep B and Hep C, they both will predispose individuals to having cirrhosis and primary hepatocellular carcinoma, which we discussed earlier. In terms of hepatitis C virus and how it affects your liver and progresses into cirrhosis, there's 4 stages. In stage 1, you have just a minimal effect on the liver function itself, and it is predominantly inflammation that you'll notice. In stage 2, there is accumulation of scar tissue, or what we call fibrosis, but the liver function itself is still not affected very much. In stage 3, there's extensive fibrosis, and this is when we start to use the term cirrhosis, and you'll see scarring, still relatively normal function. Stage 4 is when the patient has substantial cirrhosis, the liver is damaged, and you will start to see impaired function in the vital functions that the liver is responsible for. Now, the treatment can be very slow, it can halt, or it can actually reverse all the way up to stage 3. Once we get into stage 4, it is not reversible, and that extent and the rate of progression of liver damage is per the individual. It's going to vary depending on external and internal factors, and all of these things in culmination will influence the progression of that patient's fibrosis. Again, the key point here is remembering that stage 1 to 3, there's still time to reverse with treatment. So let's look at this algorithm to help us to further understand cirrhosis. We have the fibrosis itself and scarring, liver necrosis, and liver inflammation. So we're going to start with liver inflammation. In this phase, or in this arm of cirrhosis, we have pain and fever. It can also cause nausea, vomiting, anorexia, and we can also see fatigue. With liver necrosis, we see that there will be decreased bilirubin metabolism, which will present itself as hyperbilirubinemia if you take their bilirubin levels, and jaundice. We'll also have a decrease in bile in the GI tract. This will present itself with light-colored stools. The decrease in vitamin K absorption will lead to bleeding tendencies, and because there will be an increase in urobilinogen, this will cause urine to look dark. With liver necrosis, we also see hormonal changes. There will be a decreased hormone metabolism, increased androgens and estrogens. So that will lead to gynecomastia, loss of body hair. There'll be differences in your overall menstrual function. It could be dysfunctional altogether. You might see spider angiomas and palmar erythema on these patients, and this is all due to the increased androgens and estrogens that are not being metabolized correctly. Additionally, we'll see increased antidiuretic hormone, or ADH, and aldosterone, which will lead to edema. The decrease in the metabolism of proteins, carbs, fats will lead to hypoglycemia, and because there's a decrease in plasma proteins, this will result in ascites and edema. Things that you might see in terms of biochemical changes or labs, we will see elevated AST and ALT enzymes, elevated bilirubin, low serum albumin, that connects right back to that decreased plasma protein causing ascites and edema. We'll have prolonged prothrombin time, or PTT. This will cause an increase of bleeding, and elevated alkaline phosphatase. Liver necrosis will lead to liver failure, hepatorenal failure, hepatic encephalopathy, hepatic coma, and death. With liver fibrosis and scarring due to cirrhosis, this can lead to portal hypertension. This portal pressure can also manifest ascites, edema, splenomegaly. With the splenomegaly, because we have increased sequestration of these blood cells, it will lead to anemia, thrombocytopenia, leukopenia, and varices due to portal hypertension. You will notice them in the esophagus, hemorrhoids, and superficial abdominal veins as well. We've reviewed this slide previously, but it's nice to connect it all back now that we've talked about the causes leading up to cirrhosis. And at the bottom, you can see the difference between the architecture and the texture itself of a normal liver versus a liver that has cirrhosis. Biliary cirrhosis differs from alcoholic cirrhosis in that the damage and the inflammation that leads to cirrhosis actually begins in the bile. Therefore, this is why we call it biliary cirrhosis. And it begins in the bile caniculi and the bile ducts rather than the hepatocytes, which we more often see in alcoholic cirrhosis. And there's two different subtypes of biliary cirrhosis. We have primary and secondary. In primary biliary cirrhosis, or PBC, it's chronic, it's an autoimmune cholestatic liver disease. And the cause is by natural killer T lymphocytes being very highly specified. This specific anti-mitochondrial antibody will destruct the small intrahepatic bile ducts. And it's thought to be superimposed by environmental antigens or infectious agents in patients that are just genetically susceptible. Although we don't actually understand what triggers this autoimmunity. We do know that women are more commonly affected, 90% more. The symptoms are rare, they rarely develop before you are 30 years old. And most often, because primary biliary cirrhosis has an autoimmune connection, it accompanies other autoimmune diseases. It is a very insidious disease process, and the pathogenesis includes inflammation, destruction, fibrosis, and the obstruction of those intrahepatic bile ducts. We usually will diagnose a patient with biliary cirrhosis based on 3 criteria. There will be biochemical evidence of cholestatic liver disease for at least 6 months. You will be able to detect anti-mitochondrial antibodies, or AMA, and you'll see the histologic features of primary biliary cirrhosis by doing a liver biopsy. And you can also do serologic tests and note that there'll be elevated levels of alk-phosphatase, and you might see other peptides as well. Patients with primary biliary cirrhosis may also have hyperbilirubinemia, hyperlipidemia, and you might even see IgG anti-mitochondrial antibodies in these patients. With secondary biliary cirrhosis, or SBC, this is going to develop when there is prolonged partial or complete obstruction of the bile duct or any of the bile duct branches. And this obstruction usually occurs because of gallstones, tumors, fibrotic structures, or chronic pancreatitis. This chronic obstruction to the bile flow will increase that pressure in the hepatic bile duct, and what we'll see is accumulation of bile in those spaces. Necrotic areas will start to develop, and then we'll see proliferation and inflammation of the portal ducts. This is what is forming the edema and the fibrosis. When we have these pools of bile forming in these ducts, they can rupture, and they rupture into these surrounding necrotic areas. The clinical manifestations are very similar to that of primary biliary cirrhosis. So you'll see the jaundice as well and pruritus, and these are the most distressing symptoms of secondary biliary cirrhosis. Right upper quadrant pain is also common with a low-grade fever, and this is because oftentimes with secondary biliary cirrhosis, there will be that bile duct inflammation, which is called cholangitis. I just wanted to give you a reminder of bile. Bile is alkaline, it's bitter, it contains bile salts, cholesterol, and bilirubins, lights, and water. Now, conjugated bile acids are required for metabolizing fats. And remembering that bilirubin, this is where heme turns into bilirubin, which turns into bilirubin, becomes unconjugated bilirubin to conjugated bilirubin, breaks down into urobilinogen, and you can find the breakdown of these products in urine and feces. And this will help you to better understand the next few slides. Cholecystitis is a disease of the gallbladder, and it can be acute or chronic, and most often it's because there's some gallstone that's lodged into the cystic duct. And that's really important in terms of anatomy. And this obstruction will cause that gallbladder to be distended, irritated, inflamed, and the pain is usually very similar to the pain that someone might experience if they have gallstones. But it's just because that there's a gallstone in that cystic duct. Now, pressure against the distended wall of the gallbladder, this will result in decreased blood flow, which will lead to ischemia, necrosis, and eventually it could lead to perforation of the gallbladder itself. So things that you would note in your patient would be fever, leukocytosis. They might have some rebound tenderness if you were to do an abdominal exam, lots of guarding of their abdominal wall muscles. These are common findings. If you were to get some labs, you would see elevated bilirubin, elevated alkaline phosphatase. Regardless of these symptoms, the acute abdominal pain of cholecystitis has to be differentiated between pain of other GI diseases, such as pancreatitis or intestinal vascular insufficiency, pyelonephritis, things like that. We have to be able to decide and to know it's just cholecystitis. So how would we do this? You can actually take a picture and they can see the most sensitive imaging actually is called a cholecystinography, and this can help you to determine if there's cholecystitis. Commonly we use ultrasound and we'll use MRI to see if it is cholecystitis versus pancreatitis in other diseases. So it's the absence of the other diseases that we will determine it's possibly cholecystitis. Now, the main thing is treating the patient's pain, trying to replace the fluid and electrolytes. We might have to ask the patient to fast for some time to relieve some of these symptoms. If we think that there is bacterial involvement or bacterial infection, then antibiotics will also be prescribed. Now, most times acute attacks will require some type of laparoscopic surgery or gallbladder resection called a cholecystectomy to help release that obstruction. But it could lead to reflux of bile into the pancreatic duct, and this could cause a reflex acute pancreatitis. So we really have to determine what patients are candidates for cholecystectomy. Don't get cholecystitis confused with cholelithiasis. So whenever you hear lithiasis as the suffix, this means there's a stone. Cholelithiasis are gallstones that are formed when there is impaired metabolism of cholesterol, bilirubin, and your bile acids. And usually the risk factors are those patients that are obese or they've had rapid weight loss, patients that are in their middle age, females are more at risk than males, and those that have used oral contraceptives. With cholelithiasis or gallstones, we do know that this is a prevalent disorder in developed countries, and most often we will see that it is happening in Native Americans more so than in white adults. So about 60 to 70% in natives versus 15% in white adults. We also know that the Native American ancestry, the genetic predisposition, gallbladder, pancreatic, or ileal disease can also put you at risk. Low HDL cholesterol, hypertriglyceridemia, which is high triglycerides, and other environmental and genetic interactions can increase your risk as well. Now, going over the pathophysiology generally, these gallstones are formed again because the metabolism of and the breakdown of your cholesterol and your bilirubin and your bile salts is impaired. Now, your gallstones, they contain cholesterol, they contain unconjugated bilirubin, the calcium salts of bilirubin, fatty acids, calcium carbonate, phosphatase, and we have mucin glycoproteins all in that gallstone. And there are three types depending on the chemical composition. Most of the time, the gallstones are 70% cholesterol. Those are the most common. Sometimes we have pigmented gallstones. They're black and brown with less than 30% cholesterol. The black ones are hard, the brown ones are typically softer. And then the last class of composition are a mix of cholesterol and black and brown pigmented stones. Where did these stones first form? Cholesterol gallstones will first form in the bile when it's supersaturated with cholesterol. And that's why having a high fat, high triglyceride diet really predisposes you to gallstones. And when it becomes supersaturated with cholesterol produced by the liver, and you have a deficiency in bile acids and phospholipids to break this down, you're going to be at risk. This supersaturation does really lay down the foundation for cholesterol crystal formation. And so when this happens, your body is making microstones. These small crystals would begin to aggregate, meaning come together on the microstones, and they begin to grow. They start from microstones to macrostones, so from small to large. And this is all occurring within the gallbladder itself. And in this space, you're going to have decreased motility and biliary stasis. Things are not moving around. So they lay dormant and they're silent and they don't cause any issue until they start to become lodged and they move into that cystic or common bile duct. This is when you have pain with the gallbladder because of that contraction and that obstruction where the stone is. So in terms of what else is going on in your gallbladder, you actually have cholecystitis, but now you also have cholelithiasis because it's in the presence of the stone. Sometimes you only have a few stones, and sometimes it can fill the whole gallbladder, just like this picture here. So you might have asked yourself when I was talking about the stones, what is the difference between the brown and the black gallstones? Besides that, the brown ones are soft and the black ones are hard. The brown ones consist of calcium, bilirubinate, and fatty acid soaps, and they bind with calcium in the bile duct. And usually the pigmented brown stones are associated with biliary stasis, bacterial infections, and biliary parasites as well. More commonly, the brown stones are going to be found in patients in East Asia. The black gallstones, they're rare, and usually they form in the gallbladder. They are associated with chronic liver disease and hemolytic diseases. They're made up of calcium bilirubinate with mucin glycoproteins. So that's the difference there. Either fatty acids with pigmented brown or mucin glycoproteins with the black stones. Pancreatitis is inflammation of the pancreas, and it is relatively rare, about 15 cases per 100,000 people that live here in the US, but it is a potentially serious disorder, and the incidence is about equal men and women, but more commonly occurs during the 50th and 60th decades of life. The risk factors include obstructive biliary tract diseases, so primarily what we just talked about with cholelithiasis. Although alcoholism, PUD, which is peptic ulcer disorder or disease, abdominal trauma, hyperlipidemia, smoking, genetic factors, and there's certain medications also that put you at a higher incidence or risk for pancreatitis. And it can be acute or it can be chronic as well. And in terms of pathophysiology, pancreatitis will develop because there's going to be an obstruction to the outflow of those digestive enzymes that are produced in the pancreas. And this is caused by bile and pancreatic duct obstruction. So you can see where the ducts here will merge in this small area into the liver together. Usually with acute pancreatitis, will have very mild symptoms and they will resolve spontaneously. Most often with acute pancreatitis, this is resulting from cellular injury from alcohol, drugs, or some type of viral infection. And the cardinal manifestation is going to be epigastric or mid-abdominal pain, which is constant. What you will see is cellular injury of the acinar cells. They are going to be directly injured, but you can also have this duct obstruction that leads to edema, impaired blood flow, and ischemia, leading to the cell injury as well. Both of these processes will make it so there is intracellular and extracellular activation of the enzymes trypsin, chymotrypsin, phospholipase, elastase, and lipase. With the activation of lipase, we have fat necrosis. And with the intracellular and extracellular activation of trypsin and chymotrypsin, we will have cellular injury, edema, proteolysis, thrombosis, hemorrhage, necrosis. And you will see an interrelationship with the release of cytokines and complement activation due to inflammation. Also, if we do not help to halt the cellular injury and hemorrhage and necrosis from continuing in the process, it can lead to shock, SIRS, ARDS, ATN, myocardial depression, coagulation disorders as well. Without treatment or intervention, we can also have the translocation of intestinal bacteria because of the eventual movement of these fluids, and this can lead to sepsis, as well as pancreatic abscess, cysts, or pseudocysts that may form. In contrast, chronic pancreatitis is a progressive fibrotic disorder that's destroying the pancreas. And forms of this disease include chronic calcifying, which is the most common. We also have chronic obstructive pancreatitis and steroid responsive pancreatitis. With chronic alcohol abuse and smoking because the nicotine is going to induce oxidative stress in the pancreatic acinar cells. This is the most common cause of chronic calcifying pancreatitis, and it's because there's going to be repeated exacerbations of acute pancreatitis due to smoking and drinking, and this leads to chronic changes over time. The disease is idiopathic, though, in about 25% of the cases. Now, moving on to the next type, the obstructive pancreatitis. This is associated with fibrosis and stricture from trauma, from maybe an endoscopic procedure, abdominal blunt trauma, gallstones, or tumors. And in this type of pancreatitis, the obstructive pancreatitis, only the part of the pancreas that's distal to the obstruction is involved, not the entire thing. And lastly, with steroid responsive pancreatitis, this is associated with an autoimmune type of pancreatitis. And it has two subtypes, type 1 and type 2, which you don't need to necessarily worry too much about, but understand the difference between the three, the general differences. What you're going to notice is continuous intermittent abdominal pain. This is a pretty classic symptom of all the forms of chronic pancreatitis, except for steroid-sensitive pancreatitis. So you're going to see continuous intermittent abdominal pain with chronic obstructive pancreatitis and calcifying, which is the most common type of pancreatitis. The pain is associated with increased pressure in the ducts, increased tissue pressure, ischemia, ongoing injury, and you will start to notice changes in your pain perception as well. Many times, patients with chronic pancreatitis will experience weight loss, but sometimes they will also have fatty stools or steatorrhea. They'll experience malnutrition, vitamin soluble deficiencies, and diabetes mellitus as well. How do we treat chronic pancreatitis? Usually it's through oral lipase and insulin, and we want to prevent this degree's progression by describing lifestyle modifications to our patients, especially in the calcifying type pancreatitis. This is where we need to teach about alcohol and smoking cessation. This last section is talking about the cancers of the GI tract, and we will generally go over some of the GI cancers. Reviewing esophageal cancer, we do know that it is a rare disease that affects males more than females. It's more prevalent in China, Iran, South America, and South Africa. But here in the US, patients that smoke and drink alcohol, smoke tobacco, and drink alcohol are more at risk. Now, the squamous cell carcinomas are associated with smoking and chewing tobacco, drinking alcohol as well, and they mostly affect the thoracic and cervical areas. Adenocarcinoma, however, is more common in the Western countries, and it accounts for 58% of the esophageal cancers found in the US. And these cancers are found in the distal 1/3 of the esophagus. These are the ones that are associated with reflux esophagitis, Barrett's esophagus, patients with abdominal obesity, any drugs that decrease lower esophageal pressure, sliding hiatal hernia, and smoking. Again, these are all risk factors for adenocarcinoma. The pathogenesis of esophageal adenocarcinoma is facilitated by that chronic inflammation that causes Barrett's esophagus, reflux esophagitis, any intestinal metaplasia, dysplasia. And this is why Barrett's esophagus leads to esophageal cancer. Well, Barrett's esophagus, we have columnar rather than squamous epithelial in that lower esophagus, and this is caused by GERD, and this long-term exposure to irritants caused by GERD will cause neoplastic transformation for both adenocarcinoma and squamous cell carcinomas as well. With cancers found in the small intestines, most cases are going to be adenocarcinoma. It's more rare that the cancer will be derived from squamous cell. We do know that the most important risk factor is H. pylori. However, I will circle back and talk about that a little bit more in depth. It is worth mentioning, though, that in Eastern Asia, Eastern Europe, and South America, the incidence of stomach cancers actually remain pretty high. Some non-environmental risk factors can include family history of gastric adenocarcinoma, other things like having the blood type A, history of atrophic gastritis, pernicious anemia, or having atrophy of your gastric mucosa. These can also put you at risk for gastric tumors. And additionally, Epstein-Barr virus, or EBV, is associated to gastric carcinoma as well, but we're not really sure what the mechanism is or that link between that. Now, going back to H. pylori, only 1% of individuals, though, that have H. pylori will develop gastric cancer. H. pylori, constantly being infected with H. pylori and having severe chronic gastritis, will start to change your mucosa cells, that proliferation pattern. It will also destroy the junction of the cells and inhibit any proliferation of cells. Furthermore, H. pylori will promote cell invasibility, which increases your risk for duodenal and gastric types of carcinoma. It's also the causative link between mucosa-associated lymphoid tissue, which is MALT, M-A-L-T lymphoma. MALT lymphoma is a low-grade B cell lymphoma, originates in the stomach. So that is the reason why H. pylori is a risk factor for small intestines. But I do want you to know, I don't want you to alarm all your patients, but just know 1% of those that are infected with H. pylori will develop into gastric cancer. Other risk factors are dietary factors and lifestyle factors. With dietary factors, salty foods, using food additives like nitrates, pickled or salted foods, these can all put you at risk. Not having enough fruits and vegetables puts you at risk as well. We know that with alcohol consumption and cigarette smoking, it is going to be a risk factor for small intestinal cancers. Alcohol is metabolized by acetaldehyde, and this is a carcinogen. It decreases the production of prostaglandins, and prostaglandins help maintain that gastric mucosal integrity. Smokers have a higher incidence of H. pylori infection. In terms of environmental factors and genetic predisposition, these come together to combine the reason why you will have inflammation and progression of this gastric adenocarcinoma. The small intestinal cancers are rare and only represent about 3% of all the GI type cancers. Colorectal cancer, or CRC, is the most common cause of cancer and cancer death in the United States. However, it has been declining over the last few years because we have better screening programs, we have better technology, ability to remove polyps, and we're using NSAIDs to treat our patients. If you are over 50 years old, you're going to be more at risk. It's very rarely found in children. And we know in the United States, higher socioeconomic status is associated with having a lower incidence of mortality. Colorectal cancer is a genetic and environmental derived type cancer. In terms of epigenetics, it is associated with the development of colorectal cancer. And there are different pathways. The molecular pathway, it could be from a gene mutation, or there's just genomic instability, meaning that the cell cycle loses control of the rate in which genes will mutate. And these mutations can be inherited or acquired. In about a quarter of the cases, family history of having colorectal cancer is the reason why your patient has cancer. But it's not the only reason why or the only risk factor. The remaining of those patients that have colorectal cancer, it could be due to environmental interactions that have increased their risk. Chronic inflammatory bowel disease increases the risk of colorectal cancer after about 15 years of that disease. And so it's important that we treat chronic inflammatory bowel disease. So remembering those are the ulcerative colitis and Crohn's disease. A polyp, if you find it, can be neoplastic or cancerous. And these are what usually progress into adenocarcinomas. They are finger-like projections or mass-like projections arising from the intestinal mucosal epithelium. And most of them are going to be benign or non-neoplastic. And what you're going to find in those are just glandular and stromal cells. However, the neoplastic or cancerous polyps, they will progress into the adenocarcinomas. And if you look histologically, they have a different growth pattern. They're classified as tubular adenomas, and they have these stalk projections of the intestinal wall. These are the most prevalent. Villus adenomas with finger-like projections of the epithelial wall stalks. These tend to be larger than 1 centimeter, and this is more related to having colorectal cancer. What you're looking for with polyps that are larger than 2 centimeters, or you have more than 20, or you find that they do have this villus architecture, those are the ones that have more potential to becoming malignant. The adenomatous polyp will form in an area of epithelial cell hyperproliferation and crypt dysplasia. Now, once the adenoma transverses through the mucociliary mucosa, it's going to be invasive and highly malignant at that time. However, if we can detect it early and it's only affecting the submucosa, then they will have a better prognosis. that penetration may not occur for several years. So this is why screening and having screening colonoscopies are really important, and having the ability to screen and also do a polypectomy, removing the polyp, is going to be equally advantageous. Liver of the cancer is the leading cause of cancer death worldwide, but it's predominantly found in higher cases in Eastern and Southeastern Asia. However, here in the US, it's more commonly associated with chronic hepatitis C infection. And in terms of Hep B virus, it is connected as well, but it more so in endemic countries like Southeast Asia and Sub-Saharan Africa. It's rarely diagnosed before age 40. More commonly, it's going to be diagnosed after 60 years or older. And cancer in the liver is usually caused by metastatic spread from another primary site elsewhere in the body. Your risk factor for primary liver cancer, though, will include being infected with Hep B, C, or D, so that infection and inflammation that's associated with it, with conjunction with cirrhosis. These are going to act as carcinogens or co-carcinogens. With someone that has chronic alcohol liver disease or non-alcoholic fatty liver disease, this can also put you at risk for primary liver cancer because it's going to result in cirrhosis. If you have any exposure to mycotoxins, this will also put you at risk. Think of aspergillus, which is a mold found on corn, peanuts, and grains that have been spoiled. This will put you at a risk for primary liver cancer. If you've been smoking for more than 20 years, have hemochromatosis, which is hepatic iron overload, or if you are obese, again, this is putting you at risk for primary liver cancer. With gallbladder cancer, this is rare. However, it is a lethal disease. Cancers of the gallbladder and biliary tract. Here in the US, it rarely occurs before age 40, and again, more commonly as you get older, this time age 50 and 60. Your risk factors for gallbladder and biliary tract cancers are having gallstones. The older you get, the more at risk you are, and if you are a female. We also know that native populations in North and South America have a greater risk of gallbladder cancer, and it's more common in Chile, Poland, India, Japan, and Israel. Most of the cancerous tumors in the gallbladder are caused by metastasis, however. Primary cancer of the gallbladder are adenocarcinomas, and they're less commonly going to be squamous cell carcinomas. We don't really understand the pathogenesis. However, this chronic inflammation will trigger dysplasia of your cells and progress to a metaplasia. The infiltrated tumors will be associated with gallstones, invasion of the liver, the lymph nodes. This will all occur early on. And then as the spreading will extend, it's going to move into the pancreas, in the retroperitoneal lymph nodes, and then you also can have direct invasion of the stomach and duodenum as well because of pyloric obstruction. Infection is often going to accompany cancer of the gallbladder, and you will have generalized peritonitis, gangrene, perforation, and fine abscesses in the liver. These can all be potential complications of an infection that is associated with gallbladder cancer. The last of the GI cancers we're going to talk about is pancreatic cancer, and this represents 2.6% of all new cancers. Mortality is about 95% within the first 12 months, and this is because we don't have a way to diagnose early, and we don't have effective treatments. Those patients that use tobacco, whether it's smoking or non-smoking forms, drink alcohol heavily, have a family history of pancreatic cancer, have a long-term history of type 2 diabetes, chronic pancreatitis, they are all at risk for pancreatic cancer. If you have centralized fat distribution, if you are obese, particularly in women, this is associated with a decreased response to the chemotherapy treatments for pancreatic cancer. Now, pancreatic cancer can arise from exocrine or endocrine cells, but most pancreatic tumors, about 95%, will arise from metaplastic exocrine cells in the ducts and are called ductal adenocarcinomas. There's significant expansion of the extracellular matrix, or the stroma, from activation of the pancreatic stellate cells and a type of fibroblast in the pancreas, which also promotes inflammation, angiogenesis, and tumor growth. This is going to contribute to the resistance to therapies. Now, the tumors will arise in the small ducts, but they're eventually going to invade the nearby glandular tissue. They're going to penetrate and cover the pancreas and extend through the surrounding tissues. Ductal adenocarcinomas are the most common tumor, and they're going to occur in the head, the body, and the tail of the pancreas, so all over, and they can spread quickly and cause obstruction to the common bile duct and the portal vein. These tumors are going to infiltrate the superior mesenteric artery, the vena cava, and the aorta, and so now you can understand the connection to the blood vessels. It can actually form emboli. The tumors of the body and tail can infiltrate the posterior and abdominal wall, and this lymphatic invasion can also occur in early and rapidly involved pancreatitis because it is causing invasion of the lymph in the regional and the local nodes. There's also venous connection. The venous invasion will cause metastasis to the liver.